Hello, madam. Good evening.
Good evening.
Hi, Tarjani. Good evening.
Good
Hello,
evening.
Prashant, sir. Good evening.
Good evening, welcome.
Hi, Milan. Hi, Milan. Good evening.
We are
Hi,
live.
good evening, everyone.
Yeah, right.
Are we ready?
We are live, sir.
Okay. So good evening, friends, and welcome all of you. AIS ARC has been doing various webinars on a varied subject, and this is the 11th episode of our team. Ophthalmology has now evolved into a specialty medicine, and it has evolved so much that we have multiple subspecialties which are challenging the concepts and practices which we learned few decades back. And every specialty in itself has become a robust in itself. But unfortunately, there is a dearth of subspecialists in across the country. And still, the 90 to 95% of the subspecialty work has to be shared by the comprehensive ophthalmologists in the periphery. So was the need felt to revise the subspecialty topics with our comprehensive ophthalmologist colleagues. In this particular episode, we have collaborated with OPAI to evolve such webinar, which will be helpful to our friends in the periphery. I'm extremely thankful to Professor Usha Singh, who is the president of OPAI, Dr. Kasturi Bhattacharjee, who is vice president OPAI, and Dr. Milind Naik, secretary OPAI, for crafting such an interesting program. Let me also introduce to you about the Saransh. Practitioners like us do not necessarily have latest journals and have an access to latest journals. And many times, probably we are not inclined to go through the journals in details. And therefore, many times we lag behind in the newer concepts which are introduced into the world. So this Saransh was introduced where we expect one particular speaker to give us the gist of whatever latest thing have been published in that subspecialty in last 2 years, just the gist, which will be helpful to the common practitioner to understand or evolve his practice. Today's Saransh would be presented by Dr. Sonali Gaikwad and Dr. Sumer Doctor. And without now much ado and without much thing, I would request Dr. Kasturi Bhattacharjee ma'am to take forward the proceedings.
Thank you, Dr. Prashant, for having us this scientific webinar for the Oculoplastics Association of India. I always believe that these scientific webinars play a very crucial role in advancing the knowledge and also in advancing, in fostering collaboration of different community within the ophthalmology. And moreover, the advantage of this webinar is that it saves time and we get a cutting edge knowledge about what is happening in oculoplasty and the allied specialty. Very much thankful to the President of OPI, Dr. Usha Singh, for agreeing to have this webinar along with AIOS ARC. So without wasting much time, I'd like to introduce Dr. Mukesh Sharma and Dr. Milind Naik, who will be moderators of today's session. Dr. Mukesh Sharma is the Chairman Scientific Committee of Oculoplastics Association of India, a very dynamic personality and a very talented personality. And along with him, we have Dr. Milind Naik, who is the Secretary, Honorable Secretary of Oculoplastics Association of India. Very great academician and a great clinician, and very good mentor for many of the upcoming ophthalmologists. So Dr. Mukesh and Dr. Milind, please take up the rest of the session. Dr. Milind? So the first speaker is Dr. Aditi. Aditi is a consultant at Grewal Eye Institute, Chandigarh. She has numerous publications and has received even the Best of the Oculoplasty Award in the AIOS session, the Sujata Rao Award. We are very much privileged to have her with us. Aditi will be speaking on thyroid-associated ophthalmopathy, clinical presentation, diagnosis, and the management strategies. Over to you, Dr. Aditi.
Yeah.
Good evening, ma'am.
Yeah, before Aditi start, I take this opportunity to thank Dr. Bhavan Kule and also Dr. Kasturi for devising such a wonderful program. We have got talented speakers here. I think we would be heading for a wonderful oculoplastic symposium. All the important topics are being covered in this particular symposium. And without wasting any more time, now I request Dr. Aditi to please come forward and speak on thyroid-associated ophthalmopathy. Dr. Aditi, please. Yeah.
Thank you, sir. Highly grateful to AIOS as well as OPAI and Dr. Kasturi and Dr. Usha ma'am for this opportunity. I'll be sharing my screen. Is this visible to everyone?
Yes, you can go in the slideshow mode. Yeah, perfect.
All right, thank you. So I'll be speaking about thyroid-associated ophthalmopathy, the clinical presentation, diagnosis, and management. So to start the presentation, what exactly is the terminology? We know these three terms: thyroid eye disease, Graves' orbitopathy, and thyroid-associated orbitopathy. Often they're used interchangeably, but there are subtle differences. When there is orbital inflammation in the setting of hyperthyroidism, along with pretibial myxedema, it's known as Graves' disease. However, orbital inflammation in this setting can also be seen with euthyroid as well as hypothyroid states and other autoimmune thyroiditis like Hashimoto's disease. So it's important to know that it's not only the hyperthyroid, but as well as eut or hypothyroid, which can cause orbital inflammation and orbitopathy. What exactly is thyroid-associated orbitopathy? It is the #1 cause of proptosis. Up to 85% of the bilateral of proptosis in adults and 28% of unilateral proptosis can be attributed to thyroid-associated orbitopathy, where, because of the autoimmunity, the orbital soft tissue proliferates, leading to bulging of the eyeballs and proptosis. Now, why does the orbit, which is lying right here near the brain, become a special target in the thyroid autoimmunity, which is lying down below in the neck? Now, this is because of the unique orbital fibroblast, which has certain receptors which get activated by the circulating antibodies in thyroid disease. These antibodies transactivate the insulin-like growth factor 1 TSH co-receptor present specifically on the orbital fibroblast, causing an inflammation limited to the orbit. Depending on the cytokine milieu, you can have an inflammation which predominates the adipogenesis, leading to fatty hypertrophy or type 1 thyroid eye disease. Or you can have inflammation mediated by cytokines leading to accumulation of glycosaminoglycans and muscle hypertrophy type of thyroid eye disease. Because of the transactivation of this receptor, the autoimmunity stays independent of the systemic thyroid level. That means despite control of the thyroid hormone status, the inflammation in the orbit may continue. This is very well demonstrated by the phases, by the Rundle's curve. So the initial inflammatory phase is a dynamic phase where all the activity signs will be there, like congestion, chemosis, extraocular motility restriction, proptosis, and pain. After this settles, you have the static phase where there are chronic sequelae due to the hypertrophy of the soft tissue and fibrosis, followed by a quiescent phase 5 to 7 years later where rehabilitative surgery is done. Coming to the symptoms, these are what the patient will present with. They may have gritty sensation, pressure or pain in the eyes. They can be lacrimation or photophobia. They can be double vision or blurred vision, which require further intervention. The signs, of course, are what we elicit, and they are much more common and can be seen in up to 50% of the asymptomatic patients of Graves' disease. The commonest of these are the lid retraction, which can be visualized here, followed by exophthalmos, seen in up to 60%, the restrictive myopathy, which can lead to diplopia, and the optic neuropathy, which can cause blurred vision and can be sight-threatening due to the crowding of the orbital apex and the optic disc edema. Some eponymous signs related to thyroid eye disease include the Dalrymple sign, which is the lid retraction, the Von Graffe, which is the lid lag of the upper eyelid and down gaze, the Gifford sign, which is difficulty in averting the upper eyelid, the Cocker sign, which is the staring look, which is the characteristic of Graves' orbitopathy. The investigations include a detailed ophthalmic checkup, including visual acuity, visual fields, color vision, ocular motility, exophthalmometry to document the degree of proptosis, intraocular pressure measurement in primary and up gaze, slit lamp as well as fundus evaluation. Laboratory tests include the thyroid function test, the autoantibody level, and the imaging with the MRI or the CT scan. I find the CT scan period the most useful amongst these because it can differentiate between the muscle predominant or the fat predominant type of thyroid eye disease. It can detect the subtle enlargement of the muscle belly with sparing of the tendons as visualized here. Also, it serves as providing the bony landmarks for future planning of rehabilitative decompression surgeries. Coming to the grading of severity of the thyroid-associated orbitopathy, we have a lot of classifications, the NOSPECS, the VISA, the Clinical Activity Score, and the UGOGO, that's a European Group on Graves' ophthalmopathy classification system. Most of these are quite detailed. We look at this VISA classification form, and we see that it's quite comprehensive, covering the vision, inflammatory symptoms, strabismus, appearance. Along with this, you have the objective or the clinician measures and what the patient feels as the subjective inputs. In the OPD, it does become a little cumbersome to do this. Therefore, the preferred scoring system is the Modified Clinical Activity Score by Moritz et al. It's a 10-point scale. At the initial presentation, we measure the first 7 points, which include the spontaneous or the gaze-evoked or orbital pain, the eyelid swelling, erythema, conjunctival redness, chemosis, as well as inflammation of the caruncle. The follow-up assessment includes the point 8, 9, 10, that's increase in proptosis by more than 2 millimeters, decrease in extraocular motility by 8 degrees, or decrease in visual acuity of 1 Snellen line. The first baseline evaluation is quite useful in the OPD to classify whether this patient is in the active, that is a score of 4 or above, or the inactive stage, that's a score of 0 to 3. So just to demonstrate the usefulness of this score, this patient has come, he's a 57-year-old male non-smoker, recently diagnosed with hyperthyroidism, complaining of pain on up gaze, there's no diplopia, and the visual acuity is 6 by 6. If we have the clinical activity score in front of us at the initial baseline assessment, this patient has gaze-evoked pain, he has eyelid swelling, he has eyelid erythema, he also has conjunctival congestion and inflammation of the caruncle and the plica, giving him a score of 5 by 7 and classifying this as an active thyroid eye disease. Coming to the management of thyroid eye-associated orbitopathy, we must remember the management is multidisciplinary, along with the endocrinologist, the physician, the ophthalmologist, as well as the radiation oncologist, and for the surgical decompression, sometimes involving the ENT as well as the maxillofacial vehicle. So coming to the mild Graves' orbitopathy, now this patient has been diagnosed with thyroid eye disease and has been referred for a baseline eye evaluation. He is asymptomatic, but if we notice, we can see the signs of eyelid retraction and there is a staring look. He's been advised to refrain from smoking and he's been started on treatment for the thyroid dysfunction by the physician. Lubricating eye drops have been prescribed to him, and this is him on follow-up. The retraction is settling down. He's being treated for the thyroid eye disease. And if we look here, 3 months out, he is taking selenium supplementation. He's quit his smoking. He is using regular lubricating drops, and there is improvement in the symptoms, and he's just suffering from a mild disease requiring only symptomatic management. A more severe disease can be presented. For example, this patient, she has proptosis and fullness. On follow-up, she also developed diplopia, which is documented on this 9-gaze photography. Because of the activity, the congestion, the diplopia, the pain, and the orbital fullness, she was started on IV methylprednisolone on weekly pulses. While taking the pulses, we can see that the congestion has resolved. Although the proptosis remains, lid retraction remains, but the patient is now symptomatically better and there's no diplopia in the primary gaze. And this is her after completing 3 months of weekly pulses of first 500 milligram and then 250 milligram IV methylprednisolone, where the lid retraction is persisting, but there is no activity remaining. And now she's waiting for the rehabilitative surgery to happen once her thyroid status has settled down. So this is the first-line medical management with immunosuppression to reduce the inflammation with the help of glucocorticoids. Just a summary about the various medical management. We have the glucocorticoids and the azathioprine targeting the fibroblasts as well as the T and B cells. Then we have the teprotumumab, which is the latest on the block, which targets the fibroblasts. Radiotherapy usually targets T and B cells. CD20 inhibitors include the rituximab targeting the B cells. Then you have tocilizumab, which targets the interleukin-6 cytokine, and selenium, which acts as an antioxidant. All of them are there to reduce the autoimmune inflammation in the orbit because of the circulating thyroid antibodies. We must always remember that the medical management does not modify the disease or reverse the orbital changes. It just controls the activity, the signs of congestion, the pain, and shortens the duration of the active stage to prevent further worsening. The patient will still remain symptomatic with proptosis, lid retraction, and will require future intervention. The exception to this is teprotumumab, which is an IGF-1 receptor inhibitor. And this has shown reversal in both active and inactive stages. However, it is not available in India yet. And even though it has shown reversal of proptosis on long-term use, there still investigation is required to see its efficacy. This is another patient with moderate to severe active disease. He's coming with pain, congestion, the activity score is high. And if we look at the MRI in this patient, we can see crowding at the orbital apex, and they can develop, he has postural fluctuation of vision, and there could be development of optic nerve damage if he is not treated. So because of an uncontrolled diabetes and a poor response to IV glucocorticoids requiring insulin, he was offered radiotherapy in conjunction with the radiation oncologist. And this is post-radiotherapy. If we look here, the proptosis remains, but the signs of activity, congestion has come down. A little bit of puffiness is also reduced. And now he's waiting for rehabilitative surgery once his active phase is completely over. This is the second line medical management with radiotherapy. Now, this is a sight-threatening Graves' orbitopathy. This patient has presented with congestive orbitopathy with severe chemosis, proptosis. There's mild exposure in the right eye as well. And she's been recently diagnosed with hyperthyroidism. But because of the severity of eye signs, she requires intervention from the ophthalmologist as well. She was started on intravenous pulse high-dose methylprednisolone, that is 1 gram as a single dose repeated on 3 consecutive days with daily monitoring of parameters. And on continuing the intravenous methylprednisolone, there's reduction in the congestion and the chemosis. The eyeball is, she's getting symptomatically better, but there's not complete resolution. This is after completing 8 weeks of the pulse after the initial presentation. She's completed the pulses and now she's planned for a decompression because of inadequate response. Post decompression, we can see that the eyeball has gone back slightly. However, the strabismus has developed. The congestive features have now completely gone away and there is no longer any chemosis or active thyroid disease. Further rehabilitation will be required for improving the diplopia. So what is orbital decompression? Orbital decompression refers to a surgical technique where, because of the hypertrophy of the soft tissue and the muscles in the orbit, we try and make more space. We can debulk by removing the periocular fat. Along with that, with the shaving of the bones, the lateral wall, the inferior wall, the medial wall, in which we are creating more space to push the globe back into its more physiological position. It is a major surgery. There is a risk of CSF leak, injury to the orbital apex, injury to the optic nerve, and all the pros and cons must be discussed. It is offered in the emergency situation like this. Patient presented with severe chemosis. This patient is from Shankar Dev Netralaya, Guwahati. And after surgical decompression, this is what he looks like. The proptosis, chemosis has reduced, but now he requires definitive surgery for management of the diplopia and the globe dystopia. So we know that the rehabilitative surgery can also be done in the elective phase. This patient presented with diplopia and ongoing fluctuating systemic thyroid levels in August 2023. He was initially managed with Fresnel prisms and patching to improve his diplopia in the primary and down gaze. Subsequent to this, once his thyroid had been stabilized, systemic thyroid levels were stabilized for 6 months, he was offered decompression surgery, and this is how he has responded. The orbit has gone back after the decompression in the left eye. We did a endoscopic transnasal medial wall as well as floor decompression, and his diplopia in the primary gaze has reduced. However, it's not completely resolved, and now he's scheduled for a squint surgery to obtain a binocular single vision in the primary and the down gaze. The surgery must always be sequential. First, you deposit the globe back into its place with orbital decompression. Then you do the squint correction, following which you perform the eyelid surgery. Temporizing measures, of course, include the prisms and patching for diplopia and botulinum toxin, steroid injections, and fillers to manage the lid retraction in the upper and the lower eyelid. To summarize, when a patient presents with thyroid eye disease, you categorize the disease on the basis of severity using various classification systems. When the disease is mild, you have to start the patient on lubricants. You run the baseline eye examination, call them on a routine follow-up, advise them lifestyle modification and cessation of smoking, as well as give them selenium supplementation. When the disease is moderate to severe, you start with the intravenous methylprednisolone therapy, which is anti-inflammatory. If the response is good, you can observe. If it's inadequate, you offer the second-line medical management like radiation and followed by maintenance immunosuppression. Once quiescence is obtained, you offer them decompression surgery. Along with this, you can offer prism, steroid injection for the eyelid retraction, and IOP-lowering medicines as an adjunct temporary measures. However, when the disease is severe, which is sight-threatening due to exophthalmos leading to exposure keratopathy or a compressive optic neuropathy, you have to give them high-dose intravenous methylprednisolone followed by emergency decompression surgery. The last is a rehabilitative surgery. Once the patient has obtained more than 6 months of stability, you plan them for sequential surgery, that is decompression, followed by the squint surgery, followed by the eyelid surgery. Thank you.
Dr. Milian, would you like to add something?
Yeah, hi Aditi, that was great. Wonderful summary of a very vast topic. Do we have anyone who's accessing questions from the audience? If there are any, we could take that.
Yeah, we'll have to.
Okay. In the meanwhile, one question, Aditi, in your practice, do you find any kind of common misconceptions either amongst the doctors or the endocrinologists that you wish to highlight and clarify here over and above
Uh,
your wonderful presentation?
Definitely. I think this is one of the very important point that you've asked, sir, because this is in the third to fourth decade, the patients who are presenting with features seemingly of dry eye disease. And we run a thyroid function test and we see that the antibody levels are high, maybe the TSH is borderline. They do not have clinical signs of thyroid eye disease. We do refer them to the endocrinologist to see if we can give some kind of intervention for that. And the endocrinologist just refers the patient back that it's only a dry eye, there is no thyroid disease. This is the initial stage when the thyroid dysfunction is setting in. And the patient is presenting to the ophthalmologist basically, and the endocrinologist is not able to intervene because the T3, T4 levels are stable. So
Right.
how do you counsel these patients? And they are concerned. They bring their old photographs. They say, our eyes were never bulging before. We never had this lateral congestion. We never had this gritty sensation. What is happening? What's going on?
So how do you counsel them?
So I think educating about the disease is the number one factor. Of course, lifestyle modification, head end elevation, selenium supplementation, multivitamins, a diet chart, telling them nicotine cessation, even passive smoking. In the female patients, we do not have a high proportion of cigarette smokers in the females in North India, but still educating them about passive effects of nicotine and reassurance is one thing. And repeating the thyroid function periodically. I also feel it's good to communicate with the endocrinologist, tell them what you are thinking, what you are looking at, so that they also understand that, yes, if the eye signs are presenting, the patient may develop the Graves' disease symptoms sooner or later. So about that, I'm not sure if you could answer this. If correlating the antibody levels, T3, T4, TSH is fine, but the circulating TSH receptor antibody level is high. Would you offer any treatment at that point of time, any systemic immunosuppression, if that is the situation?
Well, the systemic immunosuppression I would really guide based on the activity score. But yes, if the thyroid levels are high or if they are fluctuating, obviously that might have a bearing on the way the activity gets perceived or expressed. So I would involve the endocrinologist at that stage. Still, I would say that the antibody management would come under their purview.
Right.
And I would treat based on the activity score, which is the only objective thing we can assess in these patients. Any other comments or questions from anyone? Audience questions?
I have a question to ask.
Dr. Mukesh.
Yeah. When do you consider going for an imaging basically in a thyroid eye disease patient? Imaging means CT scan or MRI, whatever you wish.
So usually, sir, when the patient has mild signs, the proptosis on Hertels is less than 21 millimeter cutoff. I would not want any imaging. I may run an in-office orbital ultrasonography to document. But if the patient has come with diplopia or there is worsening of proptosis on follow-up, I would definitely undertake a CT scan initially. And if the clinical activity score is high on presentation, I would want a baseline imaging, because if you're planning sequential management, initially you're giving anti-inflammatory and then you later on want to plan a rehabilitative surgery, a baseline CT scan is useful in seeing the type of thyroid eye disease, whether it's type 1 that's fat predominant or type 2 muscle predominant. So just for mild symptoms where the proptosis is not significant, no imaging. But anything more than that, like diplopia or worsening of proptosis or a high clinical activity score, I would want a formal orbital imaging.
Any other viewpoint or the panel?
Dr. Mukesh, I would also add unilateral disease to this indication, because I've had cases where there were classic findings of lid retraction, proptosis. The patient was hypothyroid and fine vision. And when I imaged, there was a cavernous hemangioma sitting on that side. So if the disease is unilateral and no one has imaged ever, I would always do it more for medical legal reasons.
Correct. Actually, yeah, Dr. Kaur.
Carry on.
Yeah, actually, I also purposefully asked this
Any more
question.
comments, questions?
Yeah, actually, I asked this for medical legal reasons only, because in some of the cases, there is a discrepant bulging of recti in the apex close to the optic nerve, while the proptosis is not that severe. So, like sometime it is always prudent if the patient is not financially problematic, then it is prudent to have a baseline imaging, because you never know which of the patient is having more, which of the patient is more prone to the optic nerve compression, because there are patients where proptosis is not at all that severe, but optic nerve is imminent. Compression of optic nerve is imminent because of bulging.
I agree with you. Like shallow orbits is one of the
Correct.
indications where we would want to go in an image. Also, if we are looking at a lid retraction, I think you would like to look at the activity of the muscle and see whether it's not fibrotic, because nowadays we do give triamcinolone acetate for eyelid retraction. So that also would be another thing to look into.
I just want to add one point, like the question that was asked to Aditi, like if it is a hyperthyroid or it's a euthyroid, because we know at least 30% of the Graves' disease, they usually have a thyroid eye disease, and equally high amount of 1 to 10 or 15% of euthyroid patient also presents with a thyroid eye disease. So how do we know whether it is actually a hyperthyroid going to a euthyroid or a euthyroid presenting with the signs of thyroid eye disease? So I usually believe that all the immunoglobulins, especially the TSI is very important because it is 100% positive in Graves. But if you go for TRAB and the anti-TPO, because TRAB may or may not be positive in the Graves, and the anti-TPO, which is usually there in the Hashimoto's disease. So along with the T3, T4, THS, there's the the antibodies also assessment is very important. So even if the patient presents with euthyroid and you get a high TSI, then that means the patient had a Graves, which was not very much clinically evident, but now has come to a euthyroid. So these are some of the very important investigation that needs to be done when there's a challenging situation, whether it's a euthyroid, hyperthyroid, or like how the patient presents.
I just wanted to add a small point about compressive or dysthyroid optic neuropathy that was discussed. Just wanted to add that the simplest test of color vision in the OPD is most sensitive in picking up dysthyroid optic neuropathy. And if I do see that vision might be 20/20, but if color vision is affected, I would certainly ask for orbital imaging, preferably a CT scan, and look at the posterior coronal cuts for compression.
Sometimes in shallow orbit, even if we do a very good decompression, we do not get as good a result as we get in a bigger orbit. So what do you do in those patients? If they come with too much of proptosis, but the orbit is shallow, you've done a very good. Do you plan for something of 4-wall decompression, or you stick to a balanced decompression?
No, I would go ahead and deal the case based on patient's expectations. You would tell them that, you either have the option of having a little bit of residual proptosis, but lesser chances of new onset diplopia, lesser chances of complications during the surgery. Or if it is very important for you to have a very, enophthalmic appearance, then we probably might want to go ahead and drill some parts of the frontal bone. I would maximize on the lateral wall if required, use navigation to go right deep to the deep lateral wall, and also consider doing the floor in that situation. I would go unbalanced if it is shallow orbit with a lot of proptosis to deal with. You are muted, Dr. Kasturi. Sorry, Milind.
Should we go to the next topic now?
Yeah, as the moderator, I have to do the dirty job of reminding all the speakers that 12 minutes per presentation, and we'll have 3 minutes of discussion because we have 8 presentations. Only one is done still, and we have 2 wonderful case presentations after that. So let's stick to the time. I invite Sonam Nisar from Shankar Nethralaya, Chennai, talking about proptosis management in clinical practice, diagnostic workup and management options. Sonam?
Thank you so much, Dr. Milind, for that introduction. And at the outset, I'd like to thank Dr. Prashant Bavankale and Dr. Kasturi for this opportunity. It's a very lovely initiative. All right. So we all know that proptosis means forward displacement of the eyeball. And today we're just going to touch up upon the classification etiology approach to a patient, how to examine a patient, and few case scenarios. So you can actually classify the proptosis based on its laterality, whether it's unilateral or it's bilateral, based on the type of displacement, whether it is axial, that going straight, or abaxial or non-axial. Also based on the duration, whether it is acute, subacute, or chronic, and based on the pulsatility that you can feel, whether it's pulsatile or it's a non-pulsatile proptosis. So the most common causes, that is the etiology, remain same for most of the things, that is vascular, inflammatory, infection, post-trauma, any neoplastic, that is benign or malignant, and cysts like the dermoid cyst. It is very important for us to know the anatomy, because as they say that orbit is a Pandora's box and you can find anything and everything coming out of the orbit. So you can also understand what exactly is causing proptosis based on the age of the presentation, that is from pediatric age group till the adult age group. We have a lot of causes that are common, like for in pediatric age group, one of the most common cause of proptosis is a capillary hemangioma, whereas in an adult, you would see a thyroid-related orbitopathy. So now, if a patient is coming to you, the most important thing, as we learned in all medicine textbooks, is the history. The history is of utmost importance, because that itself will give you about 50 to 60% of a rough idea of what you are exactly dealing with. So as I mentioned, it is very important to understand the chief complaints, the duration of the complaints, any past history of any previous surgery or any other lesions anywhere else in the body, any history of smoking, and as Aditi beautifully covered, any history of thyroid or any other systemic problems as well. Next, once you've finished with the presenting complaints and past history, you go on to the systemic history and then the examination. Examination, first being the ophthalmologist, we would like to complete the entire ophthalmic examination from the anterior segment to the posterior segment. Then you go on to the local examination, that is the proptosis workup. In the proptosis workup, what all would you like to see? You'd like to actually assess for the palpable fissure height, you'd like to assess for the amount of lag of thalamus, any corneal exposure, corneal sensations, extraocular motility. Very, very important also to check for the Valsalva maneuver when you're looking at a patient with proptosis. Also, you look for the other signs of congestion, as Aditi beautifully covered all the signs of thyroid orbitopathy. I don't have to go and dwell more into that. So I'd say emphasize also on doing a gonioscopy as an ophthalmologist, because many times you might see a patient who's coming to you with a congestion, chronic congestion being treated as conjunctivitis, and then you just do a simple gonioscopy and you see blood in Schwan's canal, and you might actually be dealing with a case of indirect CCF there. If you have a swelling which is palpable, do all the palpation techniques that you actually do. You check for the swelling, whether it is well circumscribed, rim, whether the swelling is mobile, it is compressible, whether it is tender, whether it is adherent to the underlying bone or the skin. All these are the basic evaluations that you do when you're looking at the swelling as well. Another important thing that you can actually look at is the pulsatility. Pulsatile proptosis, you have direct and indirect. The direct pulsatile proptosis is very classically seen in a case of CCF, a direct CCF, whereas you can see transmitted pulsations also in a case of a meningocele or an encephalous seal. So it is very important also to look at the abaxial proptosis and measure the amount of proptosis. Well, you can actually make out where exactly is the lesion, also looking at what direction is the globe displaced in. If the globe is displaced superior laterally, that means there's something that is pushing superior medially. Inferior laterally, then there's something that is pushing from the superior medial aspect. If the globe is displaced superiorly, that means there is something which is pushing it from the down up. So we have amazing instruments to measure the amount of proptosis, and this is generally done in axial proptosis. You can use Hertel's exophthalmometer, that is commonly used. If you have an abaxial proptosis, you can use the 2-scale technique also to measure the proptosis. And of course, bruit is also something that you can auscultate, and you can see that in cases of CCF. You can hear the bruit as well. Now let's get on to the case scenarios. So here is a 2-year-old female. Parents came to us with a history of progressive proptosis over about 10 to 20 days history. Also, they gave a history of on and off fever, and the patient was looking very febrile, and there was a left globe dystopia, as you can see in this picture. What would be your next plan of investigation? We advise for imaging. On imaging, you can see a ill-defined superior mass in the superior orbit, which is pushing the globe down. You can also see a lot of flow voids within the mass. That means it is a very vascular lesion. What did we do next? since the patient was given a classical history of fever and proptosis only for the past 10 to 15 days, a very simple investigation can clinch the diagnosis, and that is the peripheral blood smear. We saw blastocytes there, and yes, you get the diagnosis, that is leukemia. You don't have to put the patient under the knife at all to get the diagnosis. The bone marrow biopsy was done, and the patient was referred to the pediatric oncologist for further management. Here is another patient which can often get confused. You see a patient with signs of febrile illness, that is fever, cold, cough. You see there's complete congestion, proptosis, mechanical ptosis. You can see also facial edema. We did an imaging for the patient, and you can see here there's classical sinusitis with a subperiosteal abscess causing orbital cellulitis. So this is very commonly seen in a pediatric age group, and this is an emergency because it can cause optic nerve compression if not dealt with on time. You start the patient immediately on IV antibiotics after doing an imaging, and many of these patients might require a drainage. Now, here is another child who came to us, parents came to us with a painless proptosis of over 1 month duration with some vague history of trauma 1 month before. You can see here there is gross proptosis, and you can see that the globe is completely displaced laterally as seen in this picture. Again, you see a large mass, and this is a case of rhabdomyosarcoma. A small biopsy is more than enough in these cases as they respond beautifully to chemotherapy. Here is another patient who came to us, a 5-year-old boy. The parents gave past history that the eye would become prominent on and off when the child had cold. But at this episode, you can see that there's gross proptosis, subconjunctival hemorrhage, and restriction of extraocular motility. An MRI scan showed multiple fluid levels and a large cystic lesion, as you can see, which is hyperintense on T2. This is a simple case of venolymphatic malformation, which is one of the most common conditions that we see, and the history of it increasing in cold is very classical. You can also do an ultrasound examination. Under ultrasound guidance, we gave 4 injections of intralesional bleomycin, and voila, you can see that the patient has responded beautifully to the bleomycin. Now, here is another patient who's 6 months old and complained of the parents came to us with complete ptosis and proptosis. You can see the very classical capillary hemangioma, which is seen all over the upper lid as well as the temporal area. And you can see multiple flow whites also on imaging. You don't have to do anything for these patients. Just start the patient on oral propranolol, start from 0.2 milligram per kg body weight and slowly escalate to 2 milligram per kg body weight under the supervision of a pediatrician. You can see how beautifully this has resolved. If it is not causing any amblyopia or vision threatening condition, you can also observe these hemangiomas for certain time as they might involute by themselves. Next, here is a case of a 4-year-old boy, and parents came to us with complaints of gradual painless proptosis associated with a decrease in vision. We went ahead and we looked at the fundus picture, and you can see that there is a gross disc edema here. Imaging was suggestive of a full fusiform enlargement of the optic nerve, suggestive of an optic nerve glioma. So unlike the old thoughts that an optic nerve glioma causes only an axial proptosis, it can also cause an abaxial proptosis. This is something that I just wanted to highlight. The treatment for this is chemotherapy. Chemotherapy does not reduce the glioma, but it will stop the progression. If it is progressing beyond that, then we might have to add radiation to this. The patient was then referred to the pediatric oncologist and the team. Let's move. In the interest of time, I'll move on to the other cases which are more interesting. So here is a case of a 58-year-old male who was a hypertensive and came to us with complaints of redness, double vision, and tinnitus. These are classical signs, and you can see beautiful corkscrew vessels there. And this is on imaging, you can see grossly enlarged superior ophthalmic vein. This was a case of direct CCF, which is draining right into the orbit. What is the treatment for that? Embolization. If you have an indirect CCF, then you can also do a DSA and you can try intermittent carotid compression as well. Now, another thing that I was mentioning about was Valsalva. So it is very, very important to do Valsalva maneuver in a lot of patients. So this girl typically complained of prominence of the eye and pain when she read namaz, like bending down forward. And when we did the Valsalva, there you can see a nice, a large vascular lesion, which is all along the orbit. Here is another case that you can see. I don't have to go more in details of it. Only I'd like to highlight that this is a very classical Coca-Cola bottle sign where you have a tendon sparing enlargement of the extraocular muscles, and it goes always more in favor of a thyroid eye disease. Here is another patient who came to us with painful proptosis and limitation of extraocular motility and pain during abduction. As you can clearly see here, the lateral rectus muscle is enlarged and it is involving the tendon. So what is this? This is a case of a IOID. These patients respond beautifully to oral steroids, but they may be steroid dependent and you might have to start them on some IMT. Many times you might require to do a biopsy also to confirm the diagnosis. Now, here is a patient, a 34-year-old male patient, complained with history of trauma. Yes.
Sonam, can you summarize?
Okay, sorry. Yes. So yes, we have multiple lesions in adults and in pediatric age group with proptosis. Imaging definitely clinches the diagnosis. And I just like to conclude saying that just remember LOC, that is the location, the onset, the clinical features, and of course, know your anatomy. Be well aware of that. Thank you.
Thank you, Sonam. Dr. Mukesh, any questions or discussions on this presentation?
In the meantime, Dr. Milind and Dr. Mukesh, I'm sharing you the YouTube and Facebook link. There are multiple questions. You can pick up few of the questions from those links.
I think it's a topic where we can go on and on.
Yeah, actually, and proptosis is such a vast thing to cover up in 10 minutes time. I think she did a good job to silently cover the major features of proptosis. But as a whole, it's a Pandora's box, actually. There are so many things in proptosis. So I think good to follow the general principles and good to always recognize the emergency situations, because in proptosis, there are times, as she has also highlighted, a few of the situations are real emergency, and we have to recognize them and treat them timely. I think sinus decompression or drainage, especially in pediatric age group, orbital cellulitis and abscess is of great importance, which she has also highlighted.
So now, would you, for the interest of a general ophthalmologist, would you like to just explain how do we do a two-ruler test to know the axial proptosis? The
Yes,
ruler test to do the axial and the axial proptosis.
So yeah, so basically you just have to take one fixed point and then we put one ruler horizontal and one ruler vertically, and then we measure the amount of displacement forward and down or up. That is how we do. I have actually a picture of that.
It will be very useful because many of the general ophthalmologists may not have a hurdles or the load, right? So most of them usually measure with the scale. And so if you can just show the picture in the meantime. So
search.
Dr. Milind, would you like to, in the meantime, introduce the next speaker?
Yes, sure. Our next speaker is going to be Dr. Senthil Nathan from Chennai. And he is a very well experienced and a perfectionist oculoplastic surgeon, a very active member of the Oculoplastics Association of India, and he's going to speak to us on ptosis, diagnosis, and treatment options. A very commonly seen topic by all ophthalmologists.
Yeah, thank you, Milind. Thank you. Can you share my screen now?
Yes, please. Yeah, go ahead.
Thank you, Milind. Thank you, Dr. Prashant. Thank you, Dr. Kasturi and Mukesh, for this opportunity. Today, again, been given a very challenging task to speak on ptosis in 10 minutes, diagnosis and management, but I'll try to do my best. So, we all know that ptosis is a very common condition which we encounter in our outpatient. It is drooping of the lids, unilateral, bilateral. And it's very important that we do a systematic examination. Why it's very important? Because we need to know what are the etiology. Whether it's congenital, you can have a wide variety. It could be congenital, it could be acquired, it could be myogenic, neurogenic, or it could be a pseudotosis also. So, and depending on how we assess these patients, we have to plan the treatment. Again, there's a wide variety of procedures available, which we will titrate depending on the etiology of the ptosis. So, basically, the ptosis workup, we have four main things: the history taking, the external examination, the actual ptosis evaluation, or the ancillary test. Coming to history, we need to know what are the age of onset. Obviously, congenital ptosis is going to be present from birth. Acquired is something which is got in between, whether it's long-standing, short, whether history of trauma, inflammation, Variability is very, very important. If the ptosis is variable, if the patient says morning it's fine, evening it droops, then you have to be very careful because it could be myasthenia. And again, past medical history is very important. And like you can see in this patient, a small child from birth, no lid crease, obviously congenital. Whereas in acquired, you see these patients, elderly patients, you see the old photographs are normal, but with time the lid droops, then it's most likely to be acquired. Trauma, there's usually a definite history. You can see this patient's mother came with history of the child banging the head on the door, following which the lid is drooping. Why it's significant is if there's history of definite trauma like in this patient, you can see if you don't do anything, you just treat them symptomatically, the ptosis completely disappears. So again, ask for history of recent trauma. Inflammation again is very important. The boy on the left you can see has orbital cellulitis, and the child on the right you can see actually is a case of rhabdomyosarcoma. So all patients with ptosis, you have to look for other causes for the ptosis, inflammatory causes. And like I said, variability again is very, very important. If the ptosis is variable, you have to think of myasthenia, which is a great mimic. Many patients with myasthenia will present with ptosis first to you. So you might be the first guy to actually diagnose the myasthenia. Family history again, you can see daughter, mother, very similar appearances. Coming to the external examination, look at the face, look at the chin, the lids, surgical scars, and signs of pseudotosis. You can see this patient has got a classical face of myogenic ptosis. You can see she's got oculopharyngeal dystrophy, and you can see the wasting of facial muscles, and you can see the bilateral ptosis as well. And patients with myogenic etiology, like for example, chronic progressive external ophthalmoplegia, you can see the wasting of the facial muscles. You can see there's absolutely no extraocular movement. The whole, there's a global decrease in the extraocular motility associated with the ptosis. And look for chin elevation, especially in young patients. You can see this patient has got a significant ptosis, but when she lifts the chin, she can see. Why it's important is if there's chin elevation, the risk of amblyopia is less, and you have time to buy. You can wait before you perform the surgery. But if there's no chin elevation, like in the child on the left, because the other eye is completely normal, then there's a greater risk of amblyopia, and you need to intervene early, you need to operate early, otherwise there's the risk the patient might become amblyopic. Again, any patient with unusual ptosis like this, for example, a neurofibroma, you always examine the body, look for other signs, like you can see the café spots in this patient. So this is a S-shaped lid of a neurofibroma. And coming to pseudotosis, you can see patients with microphthalmos, anophthalmos might actually present with ptosis. A careful examination will reveal the actual cause. Coming to the actual ptosis evaluation as such, there are a wide variety of measurements which you need to do. The most important thing is the vertical palpable fissure height. So basically a distance between the upper eyelid and the lower eyelid. So you measure it with a ruler, and the difference between the either eyes give you the amount of ptosis. You ask the patient to look straight, use a ruler to measure it. And the second important thing is what is called as the marginal reflex distance. What you do is basically you shine a torch, and you see the distance between the light reflex and the upper eyelid. So the distance between the light reflex and the upper eyelid is the MRD1, marginal reflex distance 1, which is one of the most important findings in a ptosis case. So normally it's 4 to 4.5 millimeters. Yeah, I'm not able to move. Sorry. Okay, normally it's around 4 to 4.5 millimeters. My slide is not moving. Just 1 minute.
Try the arrow at the bottom left.
Doctor, just click on the screen. Just click on the screen, and you should be good to go. Just click on the screen. Yeah.
Yeah. Thank you so much. Yeah. So depending on the MRD, we can actually grade the ptosis. So if the MRD is normally, if it is up to 2 millimeters, it's mild ptosis. If it is only 1 millimeter, it's moderate. And if you can't see the light reflex at all, it is 0. So you can see this patient, obviously you can't see the light reflex at all. So it's a very severe ptosis. Whereas in this patient, you can see on the left eye, you can just about see the light reflex on the left eye. It's MRD 1, so it's a moderate ptosis. Whereas in this patient, you can see on the right eye, he's got an MRD of 2 millimeters, so it's a mild ptosis. So again, the degree of ptosis, if it's up to 2 millimeters, it's mild ptosis. 3 millimeters droop, it's moderate, and anything above 4 millimeters drooping is severe ptosis. The next very important finding is the LPS action, or the action of the levator muscle. So depending on all this, the MRD, the levator action, the amount of ptosis will actually determine what procedure to do. So how do you do this? How do you measure the LPS action? So you ask the patient basically to look down. You put your thumb across the frontalis muscle, immobilize the frontalis, and ask the patient to look fully up. So this is how you do it. You put a scale at the upper eyelid margin, ask the patient to look completely down, immobilize the frontalis muscle with your thumb, and then ask the patient to look fully up and measure the excursion, and that will give you the LPS action. So that's how you do it. Okay. So like I said, how do you classify the levator function? 10 to 15 millimeters excursion is excellent, and anything below 4 millimeters is poor LPS action. And anything in between 5 to 7 millimeters is fair, and 8 to 10 is good levator action. So these are examples. You can see this patient with the congenital ptosis, you can see the levator action is good, whereas in this patient, you can see the levator action is quite poor. The next important finding is the lid crease. So what is the lid crease? It is the distance between the upper eyelid, the lid crease height is the distance between the upper eyelid margin and the lid crease when the patient looks down. So this is very important because in a congenital ptosis, usually there will be a very poor lid crease vis-a-vis aponeurotic ptosis, where the lid crease is very well formed, but it is highly placed. So this will give you an idea of what is the type of ptosis. Usually in males it's around 8 millimeters, whereas females it's 10 millimeters. So you can see, for example, in a patient with the congenital ptosis, a very poor lid crease, whereas in aponeurotic you can see a highly placed lid crease, a good lid crease but highly placed. So normally it's around 10 millimeters in females, 8 millimeters in males. So why again lid crease is important is when you're operating, and when you need to form the lid crease, you need to match it with the other eye. So if you don't match it with the other eye, you'll get a suboptimal cosmetic result. So you can see this patient has got a ptosis surgery done but is unhappy because we have actually placed the lid crease much lower than the other normal eye. So you can see the asymmetric lid crease. So that's very important. Another important thing is the Marcus gun phenomenon, which is not uncommon. Patients with drooping lid, when they open the mouth or chew or masticate, if the lid moves up and down, it's called Marcus gun phenomenon. You can see when the patient opens the mouth, there's complete resolution of the ptosis. So this is not uncommon at all. So just make sure you don't miss this finding, because if the patient has got a Marcus gun phenomenon, then your management will be different. And Bell's phenomenon, you look for the extra movement of the superior rectus. The patient should have a good Bell's phenomenon. The eye should move completely up. If the patient has got a poor Bell's phenomenon, then you have to be careful, because if you lift the lid completely up, you have a risk of corneal exposure post-op. Pupil again is quite an important finding. Always check the pupillary size. Any asymmetry of the pupil, for example, in a Horner syndrome, you'll have a myotic pupil. And you always examine the external examination, look at the neck, you look for signs of injury, look for signs of any surgical scars there. And if the patient has got a scar in the neck, and if the patient has got a myotic pupil, which is more prominent in dim light, so you check the pupil in dim light, they have a dilatation lag because of the involvement of the sympathetic chain. The normal pupil dilates, but the Horner's pupil does not dilate. So you have to check it in dim light, where the anisocoria will become more prominent. Whereas in a patient with the third nerve palsy, here also the patient has got anisocoria, but this anisocoria is more prominent in bright light. So when you shine light, the normal pupil constricts, but a third nerve pupil affected pupil will not constrict. Check for extraocular movements. Like I said, the elevation is very important. And in patients with neurogenic ptosis like third nerve palsy, they'll have obvious signs of extraocular muscle restriction. Again, myasthenia gravis is something which you should not miss. A great mimic, especially in patients with ptosis. You do the eyes test. You just take some eyes and place it on the lids of the patient for 5 minutes, and you can see complete resolution. If the eyes test is positive, most probably this patient has got myasthenia. But suppose the patient says, I have ptosis, but when you look at the patient looks normal, then you do what's called as a fatigue test. So you basically put the lid into fatigue, you ask the patient to look up and down quite a few number of times, and after that you can see, you can uncover the ptosis. And this again is an important way to detect myasthenia. You can see this patient has got obvious ptosis, says it's varying, and you can see when you ask the patient to look up and down, and you can see obviously after some time you can see the ptosis exacerbating, and you have actually identified a patient with a myasthenia, a young patient. So actually in myasthenia, you don't need to operate. You need to put the patient on systemic management, or you have to do a CT chest, see if they've got thymoma, and do a thymectomy if required. So again, you do the cover test. The patient can have a squint, can have a hypotropia which presents with the pseudotosis. So if the patient has got a hypotropia, always do the cover and cover test, see if they've got any squint. And if they've got a squint, just doing a squint surgery will actually make the ptosis much better. Check for corneal sensations, because you're going to uncover the cornea. The patient who's got poor corneal sensation, you run the risk of corneal exposure. Lag of thermal is again important. Tear film status is something which you should not miss. A patient with a dry eye, you do a ptosis surgery, the dry eye can worsen. And other ancillary tests, you do the neostigmine test to uncover myasthenia, the phenylephrine test in a patient with Horner syndrome, or in a patient whom you're planning to do a conjunctivomulerectomy. You put a drop of Drosin, and if the ptosis improves, then they will do well with the conjunctivomulerectomy. You can see a patient with a phenylephrine test, significant improvement in ptosis, so he might do well with a conj mulerectomy. Always documented pre and post photographs. You might also need to do feeds, in future to prove that the patient's vision is actually affected for insurance claims. How do you treat? So basically, there are four major surgeries. You have the frontalis sling, the levator, and then you have the conjunctivomulerectomy, and you have the frontalis flap. So in frontalis sling, you do basically in patients with very severe ptosis with poor LPS action, best in bilateral cases. So what basically you do, you either use a silastic rod like commercially available one, silastic rods which you can place from the lid and anchor it to the brow, or you can use fascia lata which you harvest from the thigh to lift the eyelid. And this usually works well in patients with severe ptosis, very poor levator action. It works well in bilateral cases. You can see the patients do well. But in patients with reasonably good levator function, with moderate ptosis, fat to good levator action, then you can do what's called as a levator resection, or in patients with aponeurotic ptosis, you can do a levator reattachment. And in these patients, basically what you do is these patients actually have a detached levator aponeurosis from the tarsal plate, especially in aponeurotic elderly patient ptosis. You can see the levator muscle actually detaches from the levator aponeurosis, actually detaches from the tarsal plate. And so all you need to do is reattach the levator aponeurosis onto the tarsal plate. You can see this patient, you can see the tarsal plate there, and you can see the cornea actually shining through, and he's got only a layer of conjunctiva and molars there, and the levator is actually here. So what you need to do is you need to pick up the levator. You can see that is the detached levator edge here. And so you need to put this detached levator edge onto the tarsal plate with a few vital sutures, and you'll have excellent results. So that's what you need to do. So in patients with aponeurotic ptosis or patients with good levator function, you do a procedure called levator resection or levator reattachment. So you can see now the levator has been reattached, and you can see that there's a significant improvement in the ptosis. And this is one such patient. You can see the old photographs. The patient looks quite normal, but she presents with ptosis. And for her, if you do a levator reattachment or a levator resection, they do quite well. So when will you do a conjunctivomulerectomy? A conjunctivomulerectomy is a procedure which you will do in patients with very mild ptosis with excellent or good levator action. And ideally, patients who have positive phenylephrine test, and patients with Horner syndrome do very well. So what you basically do is you invert the lid, and you use what is called as a Putterman's clamp like this, and you need to resect 8 to 10 millimeters of conj with molars, and you need to suture it, which is done transconjunctivally. So basically what we do is we use a Putterman's clamp, and the desired amount of levator, the conj molars clamped, and then you run a Prolene suture across the clamped area from one end of the lid to the other. And once you run the suture completely end to end and bring it out through the skin, you can actually resect the excess molars conjunctiva. And once you have done that, you can tie the knot outside. And patients with mild ptosis with excellent levator or good levator function, this is a very good procedure. It's a very simple procedure too with good results. And the latest procedure which has got the interest of the oculoplastic community is what is called as a frontalis flap, which was popularized by Dr. Kasturi in India. And this is a very new technique which all of us are doing, and it is a very good procedure for unilateral severe ptosis. So a patient with unilateral severe ptosis, very poor levator action, this is a very good procedure to do. Also the ideal procedure to do in a patient with Marcus gun phenomenon. And what do we do in this procedure is we raise the frontalis flap from the frontalis muscle. So we go through the lid crease incision itself and we raise the frontalis flap like that, and this is brought down and sutured to the tarsal plate. And this is excellent procedure which gives very good results in ideal patients if you follow the right technique. You can see one such patient who's got severe ptosis, already got a sling done twice with a failed unilateral silastic rod sling. And you can see with the frontalis flap surgery, it's got a very satisfactory outcome. You can also give a reasonably good lid crease. The patient has got very good cosmesis. You can see the post-op of a patient with the frontalis flap, which we did, right eye. You can see a reasonably good cosmetic outcome. The patient is able to easily elevate the eye. Reasonably good crease also. They have the usual lag of ophthalmos and the lid lag on down gaze, which happens whenever you lift the lid up. But the most important thing is it's a permanent procedure. There's no risk of the sling slippage. There's no risk of sling extrusion. You avoid scars on the leg. No question of doing bilateral surgery for unilateral ptosis. So this is an excellent procedure which will soon become very popular, I'm sure. And so to conclude, in any patient with ptosis, have a systematic approach. Proper documentation is very important, and this will give you very good results. Thank you so much. Thank you.
Well, very nice presentation, Senthil. In a short time, you could cover up all the major procedures and the examination part of ptosis very clearly. I think your talk was self-explanatory. If any of the panelists want to add or ask anything, yeah, welcome.
I think due to interest of the time, should we go to the next topic? And in case there's time remaining, we can again come to the rest of the presentation for discussion. Is it okay?
Yeah.
Yes. I think our next speaker is Dr. Marian Pauli. She is MSTNB and a fellow from Shankar Nethralaya, and she's the ICU fellow from Wills Eye Hospital, currently working in Giridhar Eye Institute in Kochi. He's going to speak to us about entropion techniques for correction. Maria?
Yeah. Thank you, sir. Thank you. I hope my slides are visible. Yeah.
It's
full screen now. I thank the AOS and Oculoplastic Association of India for giving me this opportunity. Since we are running short of time, I'll try to finish on time. So entropion, as we all know, is a condition where the eyelid margin turns inwards against the globe. It can be either congenital, involutional. Involution is the most common variant which we come across, and it can be cicatricial or spastic. So as is your pathology, so is your medicine. Always we should understand the pathology. You know, there is a loss of horizontal lid support, loss of vertical lid support, and overriding of preceptal orbicularis over pretarsal. So first, in order to determine the treatment, we have to assess the patient first. So lid distraction test is a simple test. Then do a snap back to see whether the lid is going back to surgical position or not. If it is normal, it will go back without doubling, but here you can see the laxity. Then check for medial canthal tunnel laxity and lateral canthal tunnel laxity, and look for the retractors. As the patient follow the finger down. Ideally, the lid should there is a movement of the lower lid of 2 millimeters, but if the retractors are disinserted, it will not be there. So once the evaluation is done, you can plan the treatment accordingly. So there are various surgeries described. Lateral tarsal strip is very commonly done. Then reinsertion of the retractors, everting sutures, and wedge resection to correct the horizontal lid laxity. So we'll just go to the surgical steps now. Coming to the lateral tarsal strip, after leaving local infiltration, lateral canthotomy is done with the Westport scissors. You can use radiofrequency cautery also, but should not cut the periosteum. Then do the inferior cantholysis to release the lid. So assess the lid laxity. Now make a tarsal strip. After marking is made, you can split the anterior and posterior lamella with either radiofrequency cautery. or number 15 blade. Then deepithelize the lid margin as well as the conjunctival side to make the tarsal strip. Once the laxity is assessed, the strip is made and the extra tarsus is cut. Then the strip is attached to the lateral canthus with, make sure you should attach the inside of the canthus so that the contour will be well formed. You can use either double-armed 5-0 vicryl or proline also can be used. Then excess anterior lamella is excised. Then the most important thing is form the lateral canthus so that a good contour will be formed, and make sure it should not causing any canthal dystrophy. So once the canthus is formed, close the wound in 2 layers with vicryl as well as skin with proline or non-absorbable sutures. So now, so this is lateral tarsus strip is a very easy surgery everybody can do, and without any much complications if you do it properly. Coming to the everting sutures, this is again another easy procedure. It can be done on bedside. Here the principle is you are taking the retractors so that the entropium will get corrected. So here sutures are using absorbable sutures. Sutures are starting from the fornix beneath the tarsus, and sutures will come out 2 mm beneath the lash line. Again, double-armed sutures are used, absorbable. Here I am using cutting needle instead of double-arm, and sutures are tightened to correct good eversion. In this case, I have everting sutures is combined with lateral tarsus strip. So 2 or 3 such sutures can be taken to attain good lid eversion. So coming to the retractor reinsertion, when the retractors are disinserted, we have to reinsert the retractors. In this again, the skin incision is made with number 15 blade or radio frequency cautery. Then suborbicularis dissection is done. Suborbicularis dissection is done. Septum is identified. Once the septum is identified, open the septum. So retractors can be either atrophic or disinserted or dehisced. So to identify the retractors, you have to ask the patient look up and down. Retractors will move along with the vertical movement. Septum is open. Then retractors are identified and attached to the inferior border of the tarsus with the help of absorbable sutures. This can be combined with wedge resection or even lateral tarsus strip to correct the horizontal laxity. So this is a case where we did lateral tarsus strip with everting sutures, and she did well. For me, I usually combine both vertical and horizontal laxity in most of the cases, and almost 8 to 10 years follow-up with a very good results. Post-op care, keep the bandage for 4 to 6 hours till the effect of anesthesia, local anesthesia goes off. Cold compresses can be given, antibiotics and analgesics, and tell the patient don't pull the lid for at least 2 weeks. Complications, persistent laxity if it is not corrected properly. Sometimes overcorrection can happen. Sometimes you can take the septum instead of retractors. In that case, you can get overcorrection. The lateral canthal angle dystrophy, granuloma, suture abscess, canthal dehiscence, and transient orbital rim tenderness can happen. A few words about cicatricial entropion. It occurs due to tarsal scarring or posterior lamellar shortening. The management depends upon the degree of cicatrization. In very severe, to start with, very severe cicatrizing entropion after multiple surgeries, you have to really lengthen the posterior lamella. with the nasoseptal cartilage, sclera, or hard palate. So this is a case. What we have done is you can see the extent of posterior lamellar shortening and tarsus scarring. So in this case, what we have done is we have incise the tarsus and advance the posterior lamella anteriorly and recess the anterior lamella posteriorly, and then cover the bare area with the mucous membrane graft, and everting sutures also has been taken. So this is a similar case we managed like that. You can see the extent of tarsus scarring. In moderate cases, you can actually split the anterior lamella into split the lamella into anterior and posterior recess. Then you can cover the bare area with the mucous membrane graft, and you can combine eyelash resection. A strip of eyelashes can be removed so that entropion will never come, and even if a mild recurrence happens, the lashes will not rub the ocular surface. So this is a case of thermal burns we managed like that, and he has got a great follow-up of 8 years and doing well. Similarly, Stevens-Johnson syndrome, cicatrization is very common. Mucous membrane graft with anterior lamellar recession is done, and the baby is also doing fine. A few words about role of botulinum toxin can be done in senile entropion 5 to 10 units. It basically prevents the overriding of preseptal orbicularis over pretarsal orbicularis. Again, it is temporary, again bedside procedure, and those who cannot tolerate any kind of surgery. A few words about the role of conjunctival biopsy. We come across lots of entropion, ocular cicatricial pemphigoid. Here, very telltale signs. For example, we can have cicatricial bands in the fornix. Sometimes patient gives history of chronic inflammation, or patient gives history of any skin changes in the body. In that case, we have to suspect ocular cicatricial pemphigoid and take a conjunctival biopsy and do immunofluorescence also to confirm the diagnosis, because it needs a treatment from a rheumatologist with immunosuppressants. Coming to very complicated cases, just for information, entropion following different periorbital surgeries, you can have entropion. So this is an entropion following ptosis correction. So in this case, we have to really tackle the inciting event, and just correcting the entropion alone will not help. So this was ptosis following ptosis. Condylis muscle transfer. The muscle transfer has been released and entropion got corrected. So to conclude, evaluate the patient properly and identify the pathology behind it. This technique depends on the cause. Always in senile entropion, better to correct both horizontal and vertical laxity. Always give gratifying results. Thank you.
Thank you, Marian. Any questions to Marian? If not, then I have a question. Marian, for cases where there are multiple surgeries failed, what is your choice of procedure?
For senile
you can't even make out the gray line.
Yeah. For the senile entropion?
For cicatricial.
Yeah, cicatricial. I advise...
For the...
advance the posterior lamella, pivot the terminal end of the tarsus, and cover the bare area with a mucous membrane. The one which case that I have shown, she had already undergone 4 surgeries.
Okay. And do you do anything to the levator in the surgery? Do you recess it a little bit?
Levator, no. I mean, I'll go above the levator, above the tarsus, reaching the levator.
Right. You go beyond the lid crease.
Yeah.
Okay.
Well, one question. How often you combine everting suture with your LTS? And if it is done in conjunction, as you have shown in one of the cases also, like though you showed it correctly, but you did not highlight it. I am just asking this question for the benefit of general ophthalmologists. So if you are combining them together, like how do you do it? First, you tighten the LTS or you do not tighten it. Before tightening it, you just make a strip, do a pass everting suture, and then place your tarsus strip. Like, what is the exact sequence?
Yeah, thanks for that question. Actually, so what I do is after making the strip, then I take everting sutures. Then only I will tighten.
All right. Otherwise, you won't be able to pass your everting
sutures. Yeah.
Correct.
Another way of reattaching the lowly retractors is through the transconjunctival approach. So that is also a nice approach. So when we reattach the lowly retractors to the lower part of the tarsus, then in the last bite of the suture, we make it something like a lead everting suture. We take out just subciliary. Would you like to go to the next speaker, Dr. Mukesh? Dr. Manu Saini is there. Would you like to introduce her? Or should I go ahead?
Yes, our next speaker is Dr. Manu Saini from PGI Chandigarh. And she's going to talk to us about ectropion, surgical and non-surgical approaches. Manu is already ready with her presentation.
Dr. Manu, are you there? Dr.
Yeah,
Manu?
Manu, you're muted. You can unmute yours.
Muted.
I think, Manu, can you hear us? You're muted, Manu.
Unmute.
Yeah, I think she's trying to figure out the...
Dr. Manu, are we audible?
Yes.
We can't hear you still.
Yeah.
Trying to find out.
No, we can hear you now. Dr. Manu, can you speak?
Yeah, I'm audible.
Yes, clearly, loud and clear.
Okay. Let me do the slideshow. Yeah. Yeah. Thank you for joining me today this evening. And thank you, Dr. Kasturi ma'am, OPI, AIOS for providing me this opportunity. Let's begin. Ectropion, surgical and non-surgical approaches. By definition, ectropion is outward turning. We can't see your slides, Manu. Not just something is a problem. Let me share once again. We really love your corneal neurotization presentation, and I'm sure this will be also an amazing one. Thank you, ma'am.
Ma'am, doctor, are you on a Mac or Windows?
Mac.
It will ask you for a permission. Can you just click on it?
Yeah, I didn't get any. No, I think you have done a checking, right? Yes, ma'am. Sometimes it doesn't work. So you have to close the whole presentation, the full folder. Okay. Then you again reopen. In the meantime, should we go ahead with Dr. Sahil? In the interest of time? Okay, ma'am. No issue. Switch off the whole system.
Yes, I think we should do that.
Yeah.
Yes, ma'am.
Sahil, are you there?
Yes, ma'am. Can you see me?
Yes, I can see you. I think better you
My
go.
screen.
Yeah. Same.
Hope my screen is visible.
Yes.
Very good evening to everyone, and I'm grateful to Dr. Kasturi ma'am, Dr. Malin sir, and Dr. Mukesh Sharma along with the AIS team for giving this wonderful opportunity. I have no financial disclosures for this talk. I'll just skip the anatomy part, telling some important precise points for the common general ophthalmologist that there are two punctures. The punctures could be dilated very well up to 5 to 6 times normal size. Again, the canaliculus has a vertical portion which is 2 mm and a horizontal portion which is 8 mm, opening up into the common canaliculus in 90% of the cases, which then opens up in the lacrimal sac and further into the nasolacrimal duct. The nasolacrimal duct opens at the inferior meatus, surrounded by the valve of Hasner, has a direction of downwards, backwards, and laterally. Speaking about the tear drainage, the main active mechanism is the active lacrimal pump formed by the contraction of the obliquous muscle, the pretarsal and preseptal fibers. Gravity plays a very minor role. So all these cases of lacrimal disorders would come with chief complaints of watering or mucoid and mucopurulent discharge, swelling near the middle canthus, recurrent episodes of eyelid crusting with pain and redness, and swelling at the puncta. So thorough eyelid examination is very important, along with examination of the ocular surface, including look for cases with trichiasis, metaplastic lashes, blepharitis, or an entropent which could have otherwise caused hypersecretion of the lacrimal glands. Also, examination of the lid becomes very important because any lid laxity could lead to functional epiphora. Once that is done and everything is ruled out, we need to evaluate the lacrimal vein system very well. On inspection, we can see this licus lacrimalis, which is a tier of, which is a pool of plaque between the canuncle and the middle part of the globe present, and a geomeniscus height on a slit lamp, which can be measured, and anything beyond 0.6 mm is significant. Again, a middle canthal swelling is very important. This middle canthal swelling should be placed inferior where the sac is basically located, not at or above the middle canthal swelling. So the second case is a case with internal angular trauma, and it's not case of NLDO. Examination of the puncta is also very important, whether it's normal, it's arteristic or stenosis, and whether it's opposed to the globe or not. In cases of facial nerve pulses, there could be punctal eversion and thereby epiphora. Again, in some cases, we can see fistulas. It could be congenital or acquired. And acquired fistulas, the important points are that there will be history of recurrent necrocystitis along with presence of scar all around the fistulous tract, and this fistula would be located inferiorly because that is where the gravitatory thing would come in action, and of the sac would come in action and helping secretions out, which would otherwise not be present in case with congenital fistula. So any swelling near the puncta would indicate that there is a case of canaliclitis and requires according treatment. Some other findings can also be seen, like because of recurrent episodes of watering, there could be skin discoloration, changes in texture, and a middle canthal dystopia with scarring cases with trauma. Speaking about tests for epiphora, Schirmer's and TBOT should be done to again rule out hypersecretion cases. Coming to the main very good test, fluorescent dye disappearance test. It's a very important tool, especially in cases with pediatric where syringing probing is difficult. We stain the lower conjunctival cul-de-sac with 2% fluorescent strip and wait for 5 minutes. And then if at all any dye is present, like we see in this in the case of in the right eye, that indicates that there is a block which could be either functional or an anatomical block. It is very specific in diagnosing and isolation of the obstruction. Speaking about John's dye test, it comes in 2 parts, test 1 and test 2. Helps in differentiating the partial and functional obstruction, wherein again we stain the lower conjunctival cul-de-sac with the fluorescent strip and insert a Q-tip cotton bud at the inferior meatus. Staining of the inferior meatus after 5 minutes indicates that the system is patent. However, non-staining could be either because of a functional obstruction or a partial obstruction, which is then implied with the Jones dye test 2, which I'll come on later on. A very important tool to disposal is regurgitation on pressure over the lacrimal sac, which helps in showing this mucoid secretion that comes out and is very confirmatory of and specificity is around 99%. For syringing probing is another very important tool. We require a nettleship punctal dilator, Broma's lacrimal probe, and a lacrimal syringing cannula, which is 26 gauge cannula over a 5 mm syringe. For probing after the patient being reclined after adequate anesthesia installation, adequate dilation of the system is important using nettleship punctal dilator. Then using the cannula, we probe into the system, and lateral pull of the lower lid is very important so that the vertical system comes in alignment with the horizontal system, and the cannula can be easily passed. Post which irrigation of the system, in this case, indicates that there is a clear fluid coming from the opposite punctum. And post this, what we can also do is a probing thing wherein we place in the lacrimal probe and look for a soft stop presence or a hard stop, and also measure the amount of stop that has been there. So a hard stop would indicate that the probe has reached the nasal bone and that there is no canalicular obstruction. However, a soft stop indicates that there is some form of canalicular obstruction. To measure the amount of canalicular obstruction, we place a lens forceps towards the end of the punctal end of the lacrimal probe and measure this entire length. And accordingly, the block at 2 mm, 6 to 8 mm, or 10 mm can be classified into proximal, distal, or common canalicular blocks. How to interpret the syringing findings? On syringing, if there is an immediate clean and from the same punctal regurgitation that indicates a canalicular block, immediate clean from the opposite puncta indicates a common canalicular block, a delayed mucoid to mucopurulent secretion from the opposite puncta indicates a NLD blockage. If the patient clearly says that there is saline filled in the throat, indicates a patent system. And what we need to look for is a functional or a partial obstruction in that cases. So this is where the Jones-Dye test 2 comes into role. After having done the Jones-Dye test 1, wherein we had placed a fluorescent dye into the conjunctival cavity sac. Now herein, what we do is we give a positive pressure using a lacrimal syringe inside the sac. So if now the cotton tip gets stained, so this would indicate that that there was partial obstruction, and a positive pressure because of the lacrimal syringe has caused that fluorescent dye, which has already reached the sac, to reach inside the tip and stain it. So this is the case that there was partial obstruction. However, even after that, if the tip stays non-stained, it indicates that the dye couldn't reach the lacrimal sac because of lacrimal pump mechanism failure, and therefore it indicates this is a case of functional epiphora. Imaging indications are very rare. Imaging we do with very rare indications being history of facial trauma, any hemolacria, suspicion for a lacrimal sac mass. So declocystography and decloscintigraphy at our disposal in these cases. And adequate nasal endoscopy done preoperatively is very helpful to prevent any cases of failed DCRs. So coming to management, punctal disorders, the punctal agenesis is a failure of canalicular outbudding. 90% of the cases will come along with concomitant canalicular agenesis. In mild cases, we generally tend to observe because in most of the cases with symptoms, a conjunctival DCR is what comes to help us. For punctal stenosis, the pathology being inflammation, fibrosis, and stenosis around the punctum and causing its obstruction. So the treatment of choice could be just dilation of the punctal system with a needle punctal dilator and placing in a minimum Roca stent there, or it could also be a punctal snip procedure, which could be a single snip, double snip, or 3-snip procedure. So this is a small video showing the 3-snip punctal snip wherein we have dilated the after adequate dilation of the punctal system. We snip the punctal opening. The first snip is placed posteriorly, vertically along the puncta and the canalicles, vertical canalicles. The second snip is then placed horizontally from along the horizontal canalicles length of about 2 mm. And the third snip then is placed diagonally connecting the first snip to the third snip. A minimum can be placed towards the end to prevent any further fibrosis and adequate opening of the system. This was one case wherein we had just dilated the puncta and placed in a mini Minoka. This was a patient 6 months and he was quite a lot symptomatic free. Speaking about canalicular disorders, it could be a complete obstruction or a partial obstruction. Canalicular partial obstruction, we have to do an intubation with a silicone tube. However, in complete obstruction cases, especially those are distal blocks, canalicular trepanation with stent is the treatment of choice. However, again, for proximal blocks, a conjunctival DCR with Lester Jones tube is what we need to do. So this is a lacrimal canalicular trepine, which is 21 gauze needle covered with a plastic sleeve and a syringe attachment towards the end, which is a green color. There is a silent piece inside, which helps in guiding the lacrimal canalicular trepine inside the system. This is a short video showing the lacrimal canalicular trepanation surgery after achieving adequate anesthesia and dilating the punctal system so that we do not cause any undue trauma to the punctal proximal system with the trepine, and also reconfirm our findings by probing the same on table. The lacrimal trepine is then placed inside the lacrimal system, into the canalicular system, and with the stylet in situ. You just saw that I took out this stylet here. So that stylet has to be there till we reach the soft stop. Once we have reached the soft stop, the stylet is taken out, and using a to and fro rotation movements of the fingers, the trepine is then proceeded, and any sensation of giveaway or a hard stop indicates that the system is patent. The same can be again checked by syringing later on and asking the patient for any slang was felt in the throat. This also procedure could be adjunct with a minimum rocket towards the end, and which could be taken out 3 months. Speaking about conjunctival DCR, this is basically a bypass procedure connecting the licus lacrimus area directly to the middle meatus using the Pyrex tube, which is a Lester Jones tube. I'll skip the steps in view of lack of time. This is the patient where we had done the same surgery, and this we can clearly see that there's an adequate clearance of the dye. And post-op 6 weeks. However, the main problem with the surgery is high rates of tube extrusion or displacement. Speaking about NLDO, the presentation could be acute and chronic declocysticitis. In most of the cases, we get away with topical antibiotics and systemic antibiotics as the treatment of choice. However, if required, drainage can also be done locally. Congenital NLDO is again very important area where the management protocol is basically a very good counseling of the parents and telling them that the adequate lacrimal trigger self massage would help in opening the system up till 90 to 95% cases in most of them. The massage should be done 3 to 4 times a day, and Each massage should have a 10 strokes. The placement of the little finger is very important over the medial canthal area, just lateral to the anterior lacrimal crest, placing moderate pressure over the lacrimal sac, thereby creating a downward hydrostatic pressure onto the obstructive area and thereby opening up the block. In cases not responding to articular sec massage after 6 to 9 months, stringing and probing could be done under anesthesia, wherein lacrimal probe is passed to the upper punctal system, directed downwards, laterally and backwards, and the membranous obstruction is opened up, and the same can be cross-checked by using endoscope and the placement of the semen in the inferior meatus. Towards the end, patency can be checked using a suction catheter tube. Speaking about decrocystal rhinostomy, that's the gold standard surgery for nasolacrimal duct obstruction where the canal are acquired. Therefore, pre-operative thorough evaluation and a post-operative evaluation is very important. I'll just skip the surgical video here. It could be external or endoscopic DCI. Endoscopic DCI that has very good equivalent outcome rates, besides getting advantage of no facial scar, less disruption of the medial canthal anatomy, and decreased operative time. Failed DCR could be because in the early times, in the first 4 weeks, because of hemorrhage, wound dehiscence, or wound infection. Within 3 months, it could be because of granuloma formation down at the rhinostomy site or some syndrome, and later on because of fibrosis. How does the pediatric DCR differ is basically in children's anatomy, anterior lacrimal crest is minimally developed, thus causing difficulty in creating osteotomy, as well as a partial ethmoidectomy is required to allow successful anastomosis between the lacrimal sac and nasal mucosa, and this pediatric age group as the ethmoid air cells are present at birth. Intubation DCR as well as mitomycin C are good adjuncts to pediatric DCR. In cases where proximal clavicle blocks are there is a failed canalicular trepanation or punctal agenesis. Lacrimal buttocks is a very useful tool which provides a temporary relief from epiphyseal patients, wherein we inject 2.5 to 5 international units of buttocks right into the palpebral over the lacrimal gland and give relief to the patient over the next 3 months. Summarize, congenital NLDO, and early conservative intervention is the key. Comprehensive evaluation, including patient history and physical examination, is very much important. Thank you.
Yeah. Dr. Mukesh, you're there?
Yeah, actually. Very nice presentation, Dr. Sahil. I think you have covered up most of the things very nicely. I think I remember listening to you saying that you keep stent for 3 months or so after doing lacrimal trepanation.
6 weeks to 3 months.
All right. So nowadays we prefer keeping stent not longer than 6 weeks in all cases, actually, because keeping them longer generally serve no purpose, but it may incite granulation around it also. So like most people, they do not leave stent beyond 6 weeks in any indication. So that's one point which I wish to make. Otherwise, it was very nice.
Should we go to Dr. Manu now?
Thank you.
Dr. Manu, are you ready?
Yes, ma'am. My slides are visible, ma'am?
Yes.
Yeah. Thank you for providing me this opportunity. And thank you, Dr. Kasturi, ma'am, OPI, AIOS. I shall begin the ectropion surgical and non-surgical approaches. By definition, ectropion is outward turning of lid margin, and successful treatment depend upon the recognition of its underlying pathophysiology. Most of the information can be obtained by the 3 P's: pinch, pull, push test. As it has been already covered, so I am covering the surgical aspect. Broadly, it is classified into 5 types: congenital ectropion, involutional, cicatricial, paralytic, and mechanical. Congenital ectropion is rare to occur and rare if occur in isolation without associated with the syndrome. It is usually associated with the uriblepharon and caused by the vertical shortening of the anterior lamella. Therefore, management includes lateral canthoplasty with or without full thickness skin grafting. This is an algorithm that helps to differentiate the different type of ectropions. The shortage of the skin indicates a cicatricial ectropion. If there is absence of normal lid closure, then it is paralytic ectropion. Else we are dealing with involutional ectropion and absence of the lump or mass over the lid. So coming to the surgical decision making, a localized linear scar can be corrected with the Z-plasty by lengthening the skin at the contracture short video of Z-plasty. Yeah, my video is not running. Yeah, it's not running actually. Slides are not moving. Something is. Sorry for these glitches. Am I audible, ma'am?
Yes, you are, but your slides are not moving. Maybe you need to unshare and then share again because of the.
Actually, it's hang up. It's
Yeah.
not escaping also. Something wrong happened.
So
It's not playing on your screen either.
Yeah. So it's not playing on my screen. And it's not moving forward also.
you need to stop sharing and then again connect.
Actually, not showing anything. Oh, something had happened. It's not stopping also.
Can you click on the screen once
Yeah.
and just try to play it again?
Actually, I'm not getting a arrow.
Cursor.
Just click on the screen. I mean,
Okay.
in any which way.
So sorry. It's consuming so time. It's not moving.
Or you can stop and reshare, please.
Yeah, it's not moving. Could you stop it?
Probably frozen. So
Yes, sir. Yes, sir.
you might try.
I've stopped it. Can you just
Try
reshare?
clicking escape.
Yes.
I stopped it.
Yeah.
Just reshare. Just click on the screen. You should be good to go.
Yeah, it's means cursor is moving on. It's taking some time. Yeah. It's not responding.
You need to stop the entire application and then start.
Okay, and once again I'll try, otherwise I'll do that.
G. Not moving, doctor.
Not moving?
No.
Yeah, my side is also not moving. Shall I minimize and then do that?
Yeah.
If you can do without the presentation or video, I think that would be better.
Actually, it's not moving forward now.
Can you just close the application? I'm stopping. You can reshare.
Okay, okay.
Just open the PPT. You should be good to go.
Yeah. Now it started. I'm responding.
Dr. Manu, we can move on to the next one. You can restart
Yes,
the
sir.
laptop.
Yes,
I think
yes,
your applications are stuck. So you can just restart the entire PC.
Okay, okay.
Thank you. Thank you.
Just disconnect me because it's not responding from my side.
Okay, you want me to? Okay.
It's not responding.
You can just restart the entire laptop or a Mac
Yes,
if
sir.
you have. Please do so.
Yeah.
So I think meanwhile we can request the next speaker, Dr. Shefali Chahar, to present her talk on evisceration and enucleation.
I hope my screen is visible.
Yes.
A very good evening, everyone, today. Thank you so much to AIOC and ARC and OPI for having me here. And I'm honored to be present with all of you today. My topic is enucleation and evisceration, and I'll be discussing upon the types and techniques. I have no financial interests or disclosures, and all the pictures have been used with informed consent. So destructive procedures of the eye, as we know, are enucleation, evisceration, and exenteration. These are some of the oldest eye surgeries performed. So as you can see in this picture, we have moved from the barbaric way of doing the surgery to a very refined surgery, which is done at every step, where we recognize the tissues, respect them, and properly utilize them to optimize our results for the rehabilitation of these patients. And these surgeries are still constantly evolving in their ways and methods, and for providing adequate cosmesis. So what is our goal for these surgeries? The goal is to have an ideal socket. What we are essentially doing is we are taking off the eyeball, or we are scooping off the content. So we have to replace that lost volume with an implant, and also have a good wet conjunctival lining surface where we can place a customized ocular prosthesis, which not only gives us a static cosmesis, but also a very good dynamic cosmesis. So just a word about enucleation, although we all are aware of it. It's a removal of the entire globe along with the optic nerve, and evisceration is essentially just scooping out the contents, and we are left behind with a scleral shell here. So indications are many, and we know of them, but I would like to stress upon the absolute indications for enucleation, which are intraocular malignancies or ocular surface malignancies, which have scleral invasion, or we want to rule out intraocular extension in them. Infections, mostly we prefer eviscerations, and there are certain other indications where in case-based we can decide about the enucleation or evisceration surgeries in them. Just a word before we deep dive into the techniques of these surgeries, that clinical evaluation is so very important. We should have a good, thorough history from the patients so that we know the etiology of why the eye is like that, how it is. Any prior procedures done, any VR procedures, any glaucoma surgeries, any prior treatments that the patient has undergone, so that we know what we are dealing with. Examination actually helps us decide what we are going to do on table and prepare for the surgeries. So we need to know if any contraction is going on, how is the conjunctival lining, whether we'll be able to close it at the same sitting, or we would require any AMG, or in the second sitting, band, buckle, any other, as I said, glaucoma devices that might be there. And imaging, I would like to stress that B-scan is the minimum image that we should order in these patients, so that we know what is going on in the eye, and to rule out the intraocular tumors, or CT and MRI case-based. Anesthesia, well, we are dealing with and handling muscles and optic nerves. So general anesthesia or local anesthesia with sedation might be required, and also according to the age of the patient, or local anesthesia for the evisceration. Coming on to enucleation, from the conventional techniques, we have moved on to myoconjunctival technique and minimal manipulation in case of intraocular tumors. I'll quickly show this video, although I have screenshots, and I'll be discussing in detail the steps. This is an enucleation done for the orbital retinoblastoma for the new adjuvant chemotherapy, and would logically proving that the tumor has advanced. Action here, and then we identify the muscles one by one, double tag them with silk and micro. This is all the muscles that we are handling. Identifying the organs and also making them, and essentially we are actually releasing the globe of all the attachment of our collapse the globe and strongly up the globe, and with one whole cut we need to cut the examine the node, examine the eye globe that we have enucleated, place the implant posterior to the posterior units, and have a good pre-layer closure of the posterior units first. Put the myoconjunctival sutures here. Close the anterior tunnels and the conjunctival continuous sutures, and place a conformer and do a tarsography. So before deep diving into the techniques, I would definitely like to make a point that for any destructive procedures, we need to have the eye marked in such a way that it is seen through the drape. That is so very important to recognize the eye, do an examination, dilated examination, even on table, see it with your microscope, declare the eye in the timeout, and have these systems in place before you proceed for the surgical procedure. So these are just the screenshots that I've taken from the video that I showed, and just some pearls on every step. We do the peritomy very flush to the limbus, so that we are not wasting any conjunctiva here. We use a blunt tenotomy scissor to go in all the quadrants and actually separate the Tiemann's fascia. And then one by one, we recognize the muscles starting from the medial rectus, which is closest to the insertion of the limbus. And we know the insertions, so we know where we'll find these muscles. Medial, inferior, lateral, superior rectus. These are double tagged. This is the silk sutures, which is at the insertion. This definitely we require when we are dealing with RBIs because we need traction for a good optic nerve stump. And behind it, we have the vital sutures, which is the tag for the myoconjunctival sutures that we'll be placing. The obliques are generally more fleshy and they bleed. So we can use a cautery to transect them. Prolapse the globe by pushing down the speculum and putting the traction on the eye. Also ensure that there's hypotensive anesthesia at this point in time when we are going to strum and cut the optic nerve. You strum the optic nerve, actually reach the apex, hit the bone, kind of like come 2 millimeters above it, and open the scissors as much as we want and according to the nerve length. And then we go and have a 1 bolt cut on the optic nerve and take it out. While the surgeon is examining the eyeball, hemostasis can be achieved by the assistant in the intracorneal space. And here we are holding the posterior Tenon's fascia, and we put the implant posterior to the posterior Tenon's fascia and close the posterior Tenon's fascia with the vital sutures. Here we are putting the myoconjunctival sutures. We had tagged the muscle, so through the in the respective quadrants, we take out these sutures and we tie them one by one. Then the anterior Tenon's fascia, good juicy bites are taken and closed, and conjunctiva with continuous sutures. And thus, essentially, we are ensuring 3-layered closure of the implant that we have placed inside. We place the conformer and then we do a suture tarsography. Just a word about the enucleation of the RBI. We are dealing with a tumor-filled eye, hence there should be no accidental breach. It should be minimal manipulation. The muscles should be transected completely. Also, to take care, the optic nerve stump should minimum be 15 millimeters. Definitely more than that. Aim for cutting it at the apex, so we have a 20 millimeters optic nerve length. Inspect the eyeball, and also the surgeon should send a histopathology form requesting for the high-risk features, because we have seen the patient in clinic, so we need to request for these high-risk features to the pathologist so that the adjuvant treatment can be taken care of. And in these cases, always use a non-porous PMMA implant, never a porous implant, just in case radiation therapy or things like that are planned for these babies. Coming on to evisceration, the challenges for a standard one were always implant size that we are able to put inside, wound tension, post-op pain, or wound exposure. Many modifications of the techniques exist in literature, as we can see here. And just quickly going on to the techniques of evisceration, if the conjunctiva is too scarred, we can actually use lignocaine with adrenaline to balloon up that conjunctiva. We dissect the conjunctiva well. As I said, history helps. So here we had an AGV that came out in that patient. Then we go on to make the corneal button. And after the corneal button, what we have here is the scleral shell. A tip here is to use a periosteal elevator, to use that elevator to create a cleavage all around, to have a cleavage between the scleral shell and the uveal layer, and we scoop it out in one full unit. And after that, so that no residual is remaining behind, we use absolute alcohol to denaturize any of the residual remnants, and a thorough wash, making sure that no spillage of contents happens. And then a cautery. Also, the challenge here is that we have to place the biggest implant possible. So this is when all the modifications come in. So we can have radial sclerotomies.
Shefali, in the interest of time, can you please finish it off, sum it up? Yeah.
Correct, sir. And so we can make petals out of the scleral layer so that we can place the biggest size implant here. And then again, the closure of the layers happen layer by layer, and we have a good place where we can provide a customized ocular prosthesis. Also, in infected eye, we can avoid placing the implant or do a frill excision if it's too melted. Implants are many, but the most commonly used by us is non-porous PMMA implant. And also, myoconjunctival technique has been proven to work very well for the implant and the prosthesis movement. Size, we need to make sure that an ideal size that we are replacing in the when we are taking out the eyeball should be around 20 millimeters according to the measurement that we can do. Many formulas exist, but ideal size for the adult would be around 19 to 20 millimeters. And debatable issue, but many papers exist that show that no statistical significant difference is there in the overall aesthetic outcomes of these surgeries. Complications are early or late, which can be handled. But also we should know that the journey for the patient really begins here. And in collaboration with a good ocularist, we should provide them with a customized ocular prosthesis. And this is just my take-home message. We should rehabilitate these patients well. Thank you so much for your patient listening.
Well, thank you, Dr. Shefali. I think we invite now Dr. Tarjani first to talk on contracted socket, and we'll have Dr. Manoj Singhvi at the end of our symposium. Dr. Tarjani, please.
After that, we have also two journal presentation by the two young oculoplastic upcoming.
Am I audible?
Yes, yes.
Yes.
All right. Thank you, Dr. Bhavankule, Dr. Bhattacharjee, Dr. Sharma, and Dr. Nayak, AIOS and OPAI for having me. I'm Tarjani Dave, and I'll speak on contracted socket. Ouch, my slides are not moving. Are my slides moving? I think they are now. Right. I have no financial disclosures to make, and you will see some full face photographs of my patients for which we have the consent in place. The way I've designed my talk is in two parts. First, I'll tell you about the evaluation where I go in a systematic way looking at surface, volume, prosthesis, and eyelid. And then I'll tell you what are the surgical options you have in your repertoire to correct these deformities. And eventually I'll summarize. Now, when you talk of an ideal socket, there's a lot going on there. Besides a very well done surgery that Shefali just showed, you want to have good surface, you want to have good volumetrics where both sides look quite symmetric in terms of their forward projection. You want to have a very well crafted prosthesis, and you want to have fantastic animation that the patient can put up. When his eyes close, it is very symmetric to the other side. So there's a lot going on there to give the patient the kind of cosmesis that they look for. When you don't have that, you have what is a contracted socket. So in simple words, when you have a situation where you cannot place a reasonably sized prosthesis, which either you're not able to place it or you cannot retain it inside, it pops off frequently, it's called as a contracted socket. And commonly these are either by birth where you have congenital anophthalmos or microphthalmos, or more common is the acquired presentation. Now, you can have a contracted socket that involves just the soft tissue, or sometimes you can have the bone involved as well, where you'll see a narrow palpebral fissure. You'll see contracted or microorbitism, where the size of the orbit is smaller. You may also see clinical features of a microorbitism, such as hemifacial hypoplasia that you're seeing in a child with anophthalmos versus hemifacial hypoplasia, which is not there when anophthalmos is treated on time. So what do I do? In my head, I break up these patients into 4 segments: surface, volume, prosthesis, and eyelid. When I want to assess how the surface is, I look at the fornicis, I look for the presence of lag ophthalmos over the prosthetic eye, and I look for entropion in the upper or the lower eyelid. We are quite familiar with the Gopal Krishna classification for surface loss, which has several gradings where you have either 1 or 2 or all the fornicis, or you have an end-state socket where multiple surgical attempts have been done, and despite that, you've had failure in augmenting the surface area. But there are certain subtle signs that one should always look for. Like this patient, even though he's able to retain a prosthesis, he has severe lash ptosis, he has entropion of the upper and the lower eyelid, which means the surface area, the part of the bulbar conjunctiva, which should have the palpebral conjunctiva, which should have been augmented, is probably inappropriate. And therefore, he still continues to have these. You can even have a high riding lower eyelid. And these are all surrogate markers of surface loss. When I want to look at the volume, I look at superior sulcus deformity and enophthalmos commonly. I'll show you examples of that. But certain other subtle signs, like a very heavy prosthesis, tells you that the volume in the orbit, which should have been augmented, is suboptimal. And therefore, prosthesis is taking the bulk and therefore is heavy. And that can also produce a retraction of the lower eyelid, as you see over here. Enophthalmos is very easy to make out. Sulcus deformity a little more, but then I've put up a series of pictures here for you. All left prosthetic eyes and increasing grades of sulcus deformity. No sulcus deformity looking symmetric to the other side, medial plus central, medial, central, lateral, and a total sulcus deformity. So this is how you would gauge what is the kind of volume augmentation. You also want to look at the prosthesis in terms of its appearance, how the color is, the volume of the prosthesis, its thickness, its weight, its movement, and finally its quality. And eventually, you want to look at several eyelid parameters such as ptosis, entropion, retraction, and residual sulcus deformity. Now, this is a sample patient that I put up here, let's break it down. So he had surface and volume loss. I could see that the fornices were shallow. You see a superior sulcus deformity. So I've corrected both of that together with a secondary implant FFS MMG, following which I've placed a prosthesis. He still felt he doesn't look exactly symmetric, and I did a mini ptosis surgery with a little bit of filler injection in his brow and his tear tuft, and he looks much better to this. So that's what goes into making a patient with a contracted socket satisfied through your surgical outcome. Now, I'll run you through certain case scenarios. This is a lady with congenital anophthalmia. You see a high riding lower eyelid here. She has surface loss. Inferior fornix is not formed, and obviously she has no eye and therefore no volume. And I've done a secondary implant fornix formation suture with mucous membrane graft. Implant gives volume, MMG gives surface for combined reconstruction, after which she looks like this. And then I've done a little bit of ptosis surgery to make her eyelid look better. This is another patient who had a totally contracted socket, absolutely no fornices, where we've again used a mucous membrane graft. Not the best of outcomes, but he's able to retain the prosthetic eye there. Yet another patient who's had skin graft done several years ago for the correction of surface loss. And again, what I've done in him is simply add an implant inside and put a graft over. With that, what I've achieved is reduction in the weight of the prosthesis, and just the reduction in the weight of the prosthesis post-operatively has brought the eyelid back to normal position versus the retracted eyelid. Again, another patient where a combined reconstruction is done. You can see that the MMG nicely takes up the surface area. She has a little ptosis and is awaiting correction for that. Now, this is one of the extreme examples where you'll have no eyeball plus a fracture, where it's a good idea to treat both. There's a Porex wedge implant here and a PMMA implant here to symmetrize the orbital volume. A lot of soft tissue work done here over her scars. And finally, she could wear a prosthesis happily. Yet another patient who had had multiple surgeries, you see no surface area and an exposed implant in the corner, and has had multiple surgeries after that for surface augmentation and to tackle that exposed implant to finally let him wear a prosthesis. Here again, an MMG with fornix formation suture was used. Yet one more example of severe contracted socket, treated again by reforming the entire ocular surface with mucous membrane graft and giving back the volume with the help of an implant. Again, not the best of outcomes, but she's able to wear a prosthesis. One of the other options you have is a dermis fat graft, which gives you both surface as well as volume, which you see over here. It takes a long time to vascularize, and therefore I like putting these patients on autologous serum drops, which in my opinion hastens the vascularization of a dermis fat graft. This is an example of a patient who has congenital anophthalmia and surface loss. And all I've done in this situation is to actually augment the surface with progressive custom conformers. You can see that this concentric contracture has resolved and she was able to sit a prosthetic eye comfortably. In situations where you have a shelved fornix, where the surface area of the fornix is there, but it's detached, a simple fornix formation suture can help you. And you can then, after the fornix formation suture, give a prosthetic eye to this patient. Sometimes in elderly individuals with the chronic weight of a poorly crafted prosthesis that they have used for long with poor care can also result in lower eyelid laxity, which also requires a lateral tarsal strip along with your fornix formation sutures. Now, moving on to volume augmentation, just a couple of minutes more. This is a patient who has no implant and the prosthesis does not sit well. All I've done is place an implant inside and given a new prosthesis over it. When you have an implant, but it is small, you have the option of harvesting fat from the patient's own body, say from the abdomen or thigh or the buttock, and transplanting it into the socket. And that's what is done for this patient. And you can see this is the pre-op CT and the post-op CT. The implant has moved forwards. The fat is occupying the space in the orbit. And these are almost 4 years apart, 2018 and 2023, just to show that it does have long-term outcomes as well. For certain patients who don't want a surgery, you have the option of using a hyaluronic acid gel filler. This is a patient pre-panel, post-panel. This is the site of injection. And you can see that just with that injection, the superior sulcus has built up and he's quite happy with that. Yet another patient who had severe volume loss in the socket, and all I've done in him is to place a second implant inferiorly. I used a Porex wedge, which not only brought the spherical implant up, but also supported the prosthesis. No eyelid intervention, just augmenting volume in the orbit has helped him. Few other scenarios where you deal with the eyelid, even if you've done a good socket surgery, you may end up with entropion, which is very common. And I like to use hard palate mucosal graft in the palpebral area of the eyelid as a spacer. In such patients, it gives surface. Also, it corrects the entropion. And after that, you can give a beautifully crafted prosthesis and make those patients happy. This is a patient who had surface and volume augmentation. You can see the MMG there. But after that, still has the eyelid entropion, and we placed a hard palate mucosal graft as a...
Rajni, can you summarize it?
Yes, this is my last slide. Ptosis correction is also something that you should look at. I'll just skip the prosthesis intervention in for the want of time. Thank you very much.
Thank you, Dr. Tajani. So, Dr. Kasturi, how to go ahead now? What is the status of time?
Dr. Manu, is she ready? Did she join, or we will go to the Saranj part?
Yes,
no, I can't.
It's 9 o'clock.
Yeah. Manu, can you show? Go ahead with your presentation.
Yes, ma'am. My slides are visible now?
Yes.
Yeah. I shall move to the surgical decision making. A localized linear scar can be corrected with the Z-plasty by lengthening the skin at the contracture. It's short video. May mark an incision, mark a line along the scar. From the ends, draw two lines of equal length at an angle of the 60 degree to form the shape of Z. Cut the flaps and excise the fibrotic tissue. Followed by the transposition of the flap and suturing to lengthen the skin at the scar site. Whereas generalized contracture require either full thickness skin graft or the flap. A short video of the full thickness skin grafting. Make an incision along the desired lid crease. Measure the leg of ophthalmos. Undermine skin and orbicularis oculi, followed by the dissection of any fibrotic bands of the tissues. Continue dissection till the full ectropion is corrected. Measure the defect. Cut the paper template. Harvest full thickness skin graft. Suture the graft to the bed. After defat and mashing the graft, initially 2 cardinal sutures were passed at the end, followed by 360-degree interrupted sutures. Graft is secured by passing quilting sutures and pressure bandage. Now coming to the most common form of ectropion, that is involutional ectropion. Like involutional entropion, it is essential to address horizontal lid laxity, lower lid retractor weakness of the dehiscence, and lamellar dissociation. It's important to note here that the involutional ectropion of upper lid occurred less frequently than the lower lid because effect of the gravity and increased tarsus height maintain the lid in its normal position and preventing it from developing ectropion. Horizontal lid laxity may be generalized or predominantly located to the one side. In either of the situation, it required tightening of the skin, tightening of the lid by shortening it horizontally. Full thickness resection of the lid is required in case of generalized lid laxity, whereas lateral tarsal strip is required in extensive lateral lid laxity. A video of the lateral tarsal strip. Pull the lid medially, crush the lateral canthi, cut lateral canthotomy at the orbital rim, transect the inferior crust of the lateral canthus, split eyelid at a gray line for a distance of about 5 to 10 mm depending upon the shortening, cut the retractors from the inferior border of the tarsus, remove the margin of epithelium, scrape off the conjunctiva, shorten the tarsus as desired, secure free tarsus to the periosteum just within the orbital rim. reform the cantha followed by the closure. If ectropion is because of mild to moderate medial canthal tendon laxity, then it can be corrected by medial canthal tendon plication or resection and its attachment to the posterior lacrimal crest. Whereas if ectropion is because of the retractor dehiscence, then the aim of the surgery is to reattach the retractors and shorten it. If it is more marked medially, then it can be corrected by excision of the diamond tarsoconjunctiva and reattachment of the retractors. A quick video. Excise diamond-shaped tarsus conjunctiva along with retractors 4 mm inferior to the puncta in such a way that 2/3 of the diamond lies lateral to the puncta. Pass double vertical matrix sutures. And exteriorized sutures externally by passing through the center of the diamond. Tie the sutures to make ensure that the lid and the puncta is inverted. Whereas if medial ectropion is associated with the horizontal lid laxity, then it required the combined procedure, excision of the diamond tarsus conjunctiva along with the shortening of the lid. That is known as lazy T. Video of the lazy T. Make a full thickness vertical cut of the lid. Overlap the edges. Mark the excess of the lid to be resected. Excise V-shaped segment. Invert the medial lid margin and excise V-shaped segment of the conjunctiva along with retractors, followed by the closure of incision using Barrett sutures. Pass vertical matrix suture across the tarsus at the lid margin. Tie the knots to slightly invert the lid margin, and additional sutures are passed at the posterior sharp border and at the lash line, followed by the closure of tarsus and conjunctiva. Now, I have covered the most commonly performed ectropion surgeries. However, if one is anticipating recovery, then a simple procedure is described in the literature using adhesive tapes, or alternatively, hyaluronic acid injection can be used as a temporary measures to correct a cicatricial or involutional ectropion. Hyaluronic acid is injected just below the lash line at the tethering of the skin and along the infraorbital hollow. The therapeutic effect lasts for around 12 to 18 months. To conclude, an individualized surgical approach based on the educated and thorough preoperative evaluation, including etiology and predominant location of ectropion, is mandatory, and sometimes combined surgery is required to simultaneously correct the abnormal elements. Thank you for patience listening. And sorry for the glitches.
Thank you, Dr. Manu. That was very interesting. So with this, we have come to the end of all the didactics, and we have something really hot and sizzling, whether too young and dynamic upcoming oculoplasty surgeon. I think we'll finish this, and if time permits, we can go back to the discussion. So this is a 5 minutes presentation by Dr. Sonali and by Dr. Sumer. So Dr. Sumer, yeah, please go ahead.
Good evening, everyone. I hope I'm audible.
And please introduce yourself, Dr. Sumer.
Good evening, everyone. I'm Dr. Sumer, doctor. I'm currently pursuing my fellowship in plastic surgery at Prasad, Hyderabad. I would like to thank Dr. Turi and OPAI for this opportunity. My talk today is basically on this article that was published in iJournal in 2023. So the article is titled Combined Levator and Frontalis Muscle Flap Advancement for Recurrent Severe Congenital Ptosis. These are the abbreviations used in my presentation. There are no financial disclosures. So there are two main surgical procedures that are there in our surgical armamentarium. as ophthalmic plastic surgeons for severe congenital ptosis, and that is the levator resection procedure or a supramaximal levator resection or the frontalis suspension. These procedures come with their pros and cons. However, they have a few cons which should be highlighted. One is in levator resection, we have undercorrection, eyelash ptosis, lag ophthalmos, and lid lag on down gaze. And frontalis suspension comes with the complications of harvesting and synthetic materials, along with infection and granuloma formation. Suture slippage is also a known complication. There is plenty of literature for ophthalmic plastic surgeons that we can go through on procedures of the eyelid for severe congenital ptosis. But the newest or the revived procedure that we have is the frontalis flap. Before we come to our article, I'll just give you a brief on the force vectors, which will be relevant in the subsequent presentation. The levator muscle tends to have a force vector which is horizontal or posterior in nature, and it pulls the eyelid inward and upward, whereas the frontalis muscle tends to pull the eyelid only upward. The frontalis flap is an important alternative that we have when we have to deal with undercorrection when it comes to ptosis. We can also perform a repeat frontalis suspension or a sling readjustment or a supramaximal levator resection. The frontalis flap, although a great procedure, does come with its complications. There are no synthetic materials that are used, and we can have a dynamic eyelid at the end of surgery. But it also leads to eyelid malposition, eyelid popping, and there are complications related to the lid crease and lash malposition. The aim of this study was to evaluate the outcomes of combined levator resection and frontalis muscle advancement in recurrent severe congenital ptosis. So 35 eyes of 31 patients were included in this study. It was a retrospective study that was conducted at a single center. The cases were analyzed from October 2017 to November 2020. The inclusion criteria for the study was an MRD1 of less than 1 millimeter, levator function less than 4 millimeters, and there had to be a history of previous ptosis surgery. The data was collected based on demographics, previous surgeries, the type of surgery, the date from surgery, the cause of recurrence, and scarring from the previous surgery. The baseline levator function and the MRD1 was also noted. Post-operatively, the MRD1, lag ophthalmos, eyelid crease, contour, and eyelash angle were all evaluated and graded from a scale of 1 to 3, 1 being excellent and 3 being poor. Additionally, the patients and their families were provided with a visual analog scale, which was basically a ruler which they could have graded their post-op outcomes from 0 to 100 as to how satisfied they were after the combined surgery. The patients were followed up on day 7, 1 month, 2 to 6 months, 12 months, and a final follow-up. This is a brief on the surgical technique. A lid crease was marked, and the area of dissection for the frontalis flap was marked at the crease as well. As we can see in figure B and figure C and figure D, the frontalis muscle has been dissected anteriorly and posteriorly. Figure E shows us a fat infiltrated levator, which has also been completely dissected. The flaps were combined together and attached to the tarsus for a combined effect, thereby negating the only horizontal vector that was provided by the frontalis muscle. A few points that the authors have added are to ensure free mobility of both the flaps, preserve the palpebral orbicularis, and that ensures good closure. I won't go through all the results, but these are the few prominent findings that were found. 57% patients had prominent scarring from the previous surgery, and a cause of failed sling was noted to be 68% as slipped slings in the patients that had undergone frontalis suspension surgery. The preoperative MRD1 for all the patients was 1.14 with a standard deviation of 1.56. These are the few important postoperative outcomes. The postoperative MRD1 improved dramatically in all the patients at the last follow-up. The crease and contour had an excellent outcome in 91% of the patients that were operated. And the eyelash angle, although it was average in the beginning and the visits that were conducted initially, the eyelash angles improved towards the final visit. Safe eyelid closure was ensured in all cases. And the scale that I had mentioned prior had an average rating of 90 out of 100 for all patients and their families. So to summarize this article, it gives us an insight on this combined procedure, which does not have any harvesting concerns or any alloplastic materials that we have to deal with. The traction forces of the frontalis is redirected horizontally to a more physiological direction. Less resection of the levator is required, which is fat infiltrated due to the additional action of the frontalis. And one patient also underwent repeat surgery and had a good outcome. So this ensures repeatability of the procedure. So a direct frontalis flap advancement is a reliable management strategy for recurrent severe ptosis. Adjuvant levator resection also helps to address the eyelid malpositions and treat them appropriately. A few limitations that were cited by the author: it was a retrospective study. It was a small cohort of patients of just 35 eyes. And the author himself suggested that a randomized controlled trial comparing this technique with frontalis flap alone versus frontalis suspension would give us a better outcome. A few points on the critical analysis of this article. A longer and regularized follow-up would have given us a better idea. As we know, slings and ptosis correction for congenital ptosis, we get a better outcome and a better idea at 5 years or a longer follow-up. A single surgeon performing the technique would help standardize the entire study. We could have used technology to eliminate bias and also eliminate variability between observers. Effectiveness of this study on virgin eyes which have not been operated previously would give us a better baseline for this technique. And a preoperative scale could have also been provided to the patients and their families to perceive how much improvement has actually happened from the last surgery. A subgroup analysis on the frontalis suspension versus previous levator resection cases would also give us a better insight on the findings. Thank you.
Thank you, Dr. Sumit. That was an excellent presentation. Can you stop your slideshow? Sumit, Dr. Sumit? Yeah. Okay. So what I mean to say, actually, frontalis sling is, frontalis flap surgery is not something very new. It was started by Song et al. In 1902. And then it got modified by multiple authors, like Nice was the first where he used frontalis with the orbicularis. And now we have seen so much of modification, like the tripartite, no? There was one theory. Then the FEMA theory came where they are using the aponeurosis, which you have mentioned. And now the concept is the fulcrum. So what they're using the fulcrum, which can be a levator aponeurosis, which can be a superior arcus marginalis or the orbital septum. But what I really liked in your presentation was your second last slide, where the author has shown that the legophthalmos was much less. The picture that he have shown, the post-operative and one with the absence of legophthalmos. I feel that when you use any of this fulcrum, then the legophthalmos is much less than without using it. So that's why we have so much of variation in the post-operative result. And I feel it is really a nice technique that which you have mentioned. And like it has got multiple advantages as compared to the disadvantages. So anything more that needs to be added? Dr. Milin, I think you also doing frontalis, Dr. Tarjini, Dr. Mukesh. Would you like to add something more?
Well, what was the average follow-up in your study, in the study which you presented?
So all the patients had a follow-up of longer than 1 year, but the last follow-up has not been mentioned. Average follow-up of 18 months.
All right. Well, I am keeping my finger crossed because I have started doing this surgery for around a year or so only. And in the limited time period and limited number of patients, I am seeing some patients having late droop. So like they are behaving as levator resection done in severe ptosis with relatively poorer levator function. So yes, patient with moderate levator function, it's a wonderful procedure, at least in my hand, but poor levator function, I am keeping my finger crossed, but I don't have experience as much Dr. Kasturi is having, and Dr. maybe other people.
I'd like to mention, because of sake of discussion, when the muscle contracts, it is always towards the origin. So when you make the flap, do not dissect posteriorly. You should always take the anterior dissection, and then once you advance, just do little over correction. So we need to keep the muscle strong. If we do a posterior and the anterior dissection, then the strength of the muscle decreases. We only need to advance it. So only a liberal dissection suborbicularis in the forehead region and just advance, keeping the posterior plane intact. So initially when I had also done both posterior and anterior dissection. And then I have realized there was definitely you're right, that some amount of, undercorrection was there. But now I have totally stopped dissecting posteriorly, only doing a liberal dissection anteriorly and advancing the flap. So I have nearing 2.5 years of follow-up. So after modification of this technique, I feel the chances of post-operative undercorrection is much less. And I use the superior arcus marginalis as a fulcrum, and I pass it through that fulcrum. So that is giving this fulcrum effect, and that is helping me, I think so.
Dr. Kasturi, I just have one question to you. Can you hear me? I have just one question.
Yeah.
Actually, I've started doing these procedures. My results are quite satisfactory. What do you do when the patients have overcorrection or undercorrection? Suppose you do a frontal flap and the patient has overcorrection. How do you tackle it? If they have undercorrection, how do you tackle it?
In my initial patients, I used to keep them just in the limbus. And I mentioned when I started doing the posterior dissection, I had some late undercorrection. So I had again redone the surgery. But now every patient on the table 0.5 millimeter overcorrection I do, every patient. Then I see by 2 to 3 months, some amount of drooping definitely comes, and at least 0.5 it comes down.
Have you had any patients with significant overcorrection where you needed to cut the suture or let the lid drop?
No, undercorrection I had.
Not overcorrection.
Yeah. I think we have one more interesting topic by Dr. Sonali. Sonali, are you there?
Yes, ma'am. Yes, ma'am.
Can you share your slides?
Is it visible, ma'am?
No. Yes.
Are my slides visible?
Yes.
Okay. Good evening, everyone. For the last talk of the day, I'll be presenting a journal article on orbital fractures and mechanism, which is a review article in the OPRS journal of the November and December issue to 2023. So my name is Dr. Sonali Gaikwad. I'm an Oculoplasty fellow under Dr. Kasturi ma'am at Sri Shankara Deva Netralaya. So this was an article published by Shinjiro Kono, Arik Vaidya, and Yasuhiro Takahashi in the November and December 2023 issue. So I'll be covering introduction, the fracture terminologies, soft tissue changes, types and mechanisms, and influential factors. So now orbital fractures are the most frequently encountered ocular trauma in the emergency department. And this was first described by Lang in 1889. So when do the orbital fractures usually occur? So orbital fractures occur when an object which is larger than the orbital aperture, it hits the orbital rim and the globe. Something like a ball or a fist or elbow or knee. That's when most of the orbital fractures occur. So there are a few fracture terminologies and patterns that have been mentioned in the review article. Blow-out fracture would be any of the orbital walls will be displaced outward from the orbital space. Blow-in would be any of the walls that are displaced towards the orbital space. Pure and impure fractures are common terms that we hear. So pure will be the one where the orbital rim is intact, and impure will be the ones where the rim is fractured. So there are a few or soft tissue changes that we see commonly. So as you can see here, the fat that's in yellow is always connected to the extraocular muscles via interfacial sheaths and connective septa. So when the fat herniates, it always drags down the extraocular muscles. And most of the times in an image seen here, as you can see, the oculomotor nerve, which is the branch supplying the inferior oblique muscle, that when the tissue herniates into the floor fractures, with the paralysis of the inferior oblique, there is incarceration of the inferior rectus also. And most likely because of this nerve here, there is the inferior oblique paralysis. As you can see in this coronal image, The shape of the inferior rectus muscle is always in an ellipse. But due to the herniation of the orbital fat, which pulls the inferior rectus down, the shape of that inferior rectus turns to a circular shape. And obviously, incarceration of the extraocular muscle is an emergent condition, which is when we plan to take up the patient for surgical intervention. Now, orbital blowout fractures are classified into open, trapdoor, and linear type. With open classified as the open fracture opens towards the paranasal sinuses. So they're all divided into comminuted or unhinged fractures, where the fracture bone, it floats freely into the paranasal sinus without a hinge. And hinged fractures will obviously have a connection on either side. With the trapdoor fracture, these are minimally displaced. They're hinged fractures with incarceration of the orbital content at the fracture site. And the bone, as you know, as a trapdoor, it snaps back into its original place. With linear fracture, these are non-displaced, which can include a trapdoor fracture, and there is no incarceration of orbital contents. So now there are three mechanisms. The first one being the buckling force, which acts mostly on the infraorbital rim here. Then there is the hydraulic force, where there is the injury is mostly to the globe, which leads to the floor fractures most commonly because of rise of intraorbital pressure. And the third one is the globe-to-wall contact mechanism, where again the globe is displaced inside the orbit, leading to the fracture. So buckling force mechanism. Leafoot was the first who proposed the buckling force theory in 1901, stating that the striking force is transmitted through the infraorbital rim to the walls without the rim fracture. Now, Nagasao et al., they found that the striking inferior orbital rim at the 30 degrees angle, it produced the largest orbital floor. Now, this happens because if we see the scans on sagittal section, the floor is rising towards the apex in a slanting manner. So most of the force, the buckling force mechanism, it acts on the floor, and that is why most of the largest fractures occurs in the floor. So this is also, buckling force are also responsible for trapdoor and blow-in fractures, and they also presume to have a blow-in type of fracture. So the hydraulic force mechanism was the first advocated by Pfeiffer in 1943. So the blow force to the globe, it raises the intraorbital pressure, resulting in the compression of the orbital walls. Converse and Smith, they emphasize that the posterior displacement of the contents was caused by the traumas was responsible for the fractures. So the inferior orbital rim, because of the hydraulic force, it likely provides a protective cushion in cases of trauma. And this has a thicker bone at the rim. So with the mean thickness of the bone decreasing as we go posteriorly, anterior to posteriorly, and medially towards the floor. So hydraulic force therefore acts more towards the center of the floor than at the rim. The globe-to-wall theory, again, Pfeiffer was the first one who suggested this theory. And according to an anatomical based hypothesis, it is suggested that the globe can be displaced at least 2.5 centimeters inside the orbit, but 2.5 centimeters from the apex. Now, as you can see in this actual CT scan, if we do a tracing of the globe and we measure it on the medial wall where the fracture is, this tracing exactly outlines the globe, and this supports the globe-to-wall theory. Unfortunately, there are no enough experimental studies to validate this theory. So there are a few differences in the fracture patterns. They Waterhouse et al., they compared the fracture sites and sizes after the buckling and hydraulic forces in unfixed cadavers. They found that the extent of the fractures was limited to the anterior and middle portions of the floor without medial wall fractures, most likely after a buckling impact, whereas a medial wall fracture was seen after a hydraulic impact. Now, the energy that is required for the hydraulic impact was comparatively lesser than it's required for the buckling force. And Darvik et al., they said that the stress produced by the buckling force is concentrated in the inferior orbital rim and more anteriorly, whereas the hydraulic force was concentrated in the orbital floor and medial wall. So there are other factors which also influence the orbital fractures, such as the fracture size. Now, fracture size, they differ among different age groups, and floor fractures are most commonly seen in young patients, and medial wall fractures are commonly seen in elderly patients. Now, there are causes of trauma, most commonly being assault, fall, road traffic accidents, and sports. Now, in mostly developed nations, the cause is usually assault followed by falls and road traffic accidents. Age.
Sonali, can you hear us? I think she got disconnected. Okay, I think we got the gist of a paper.
Should I continue, ma'am?
Yeah, please carry on. Finish it fast.
Okay. So, among the periorbital anatomy variations, a proptotic eye is susceptible to the hydraulic forces and an enophthalmic is vulnerable to buckling force. So, since children have more cancellous bone, they are resistant to buckling force, and orbital floor in children has an S-shaped curvature with a bulging in the posterior segment onto which the hydraulic forces act. So, as you can see in these sagittal scans, these are a scan of a 2-year-old female child with a shorter antero-posterior axis in the affected eye and the non-affected eye. So with a shorter antero-posterior axis, the floor and bears the brunt of the trauma, whereas compared to an adult in this image, where there is a longer antero-posterior axis. Now, these are a scan. This is a scan or sagittal scan of a 2-month-old child compared to an adult, where you can see that the ethmoid sinuses in both are quite different, whereas in the child they're underdeveloped and hence there are more attachments of the septa towards the medial wall. Now, this acts like a protective mechanism, and which is why children do not present with medial wall fractures as compared to adults. Similarly, in this picture with underdeveloped ethmoid cell sinuses. So this is it. I conclude my presentation. Thank you.
Thank you, Dr. Sonali. Can you stop your slideshow? Dr. Mukesh, Dr. Milind, would you like to add something?
Well, it was a very nice synopsis, and I think the author has compiled everything in a very detailed manner, and she has presented it nicely, actually. So, a good summary, one can say, of orbital fracture.
Thank you, sir.
Dr. Milind, would you like to add something?
Yeah, no, for me, the knowledge about the medial fall fracture being uncommon, that was really revealing. Well presented.
Thank you, sir. Even I think some new things we have also heard, especially how the globe to wall theory she was mentioning, how the globe can go up to 25 centimeter back. So because when we teach, we usually talk about buckling theory and hydraulic theory. So the globe to wall theory, we usually don't give much importance, but in that paper, that theory was, explained very well. So there's a very nice diagram also. So I think with this, we come to the end of today's webinar. I'm extremely thankful to all the speakers, especially to dynamic moderator, Dr. Mukesh and Dr. Milind, and also thankful to our president, Dr. Usha, Dr. Betheria, and Dr. Santosh could not join us today. Dr. Savri also, I'm very thankful to her because she really wanted to join, but because of some personal problem, she couldn't join us, and she has been excused for this. And I'd also like to thank all the speakers, Dr. Aditi, Dr. Sonam, Dr. Senthil, Dr. Marian, Dr. Manu, Dr. Sahid, Dr. Shaifali, and Dr. Tajini for all the excellent talk. And we have learned so much hearing you, and it was very refreshing. And the two young upcoming oculoplastic surgeons, you both have done an excellent job. It was very nice to have this hot and sizzling session at the end of all the talks. So thank you very much. And with this, we come to the end of this program. And I welcome all of you to another session because there are many people in YouTube and Facebook also joining us today. Thank you all the viewers and everyone who has joined us today. And on 13th of July, we have something very interesting coming up. That is how to manage the dark circles, which is really something very tough. And like both in terms of the pathogenesis and in terms of management. So we have a online webinar in the evening of 13th of July. So I welcome all of you to that webinar, and I hope that we can have further interactive discussion and more knowledge about this topic. So Dr. Mukesh and Dr. Milind, I request you to conclude this session.
Well, Dr. Mukesh, please conclude on our behalf.
Yeah, actually, I thoroughly enjoyed the session. It was very, very informative, and I think some of the things were new to me also. So it was really an enlightening experience. All the presenters, they deserve kudos for their effort. And also the listeners, I think all of us were benefited with this. I think Dr. Kasturi deserves a lot of applause for creating this wonderful program. So thanks once again, one and all, for participating in this wonderful oculoplastic seminar.
Thank you so much. Should we have a photograph? Can everyone come online?
You should, ma'am.
Anyone there? Yes. 1, 2, 3, done.
Thank you everyone.